Good morning, everyone. Welcome you all to the fourth in the series of Kerala Society of Ophthalmic Surgeons Scientific Committee CMA series. The first three were held in association with Kozhikode, Kannur, and Kasaragod. So this is the third one. KSOS is conducting in association with Palakkad Ophthalmic Society. The first three were quite successful, and the first one with Kozhikode had 1,900 plus views, and the second with Kannur has nearly 1,800, and the third with the Kasaragod is nearing 1,700 views. And we will have a very short inaugural session. Dr. Arup Chakravarti is not able to join because of his father's ill health, and so he had informed that he won't be able to join us today. So Dr. Gopal will be inaugurating. So it's my pleasure to invite all the delegates, the speakers, the chairpersons to this session. I now invite Dr. Gopal Pillai to formally inaugurate this meeting.
Thank you very much, Dr. Sreeni. It has been an immense pleasure to be a part of this wonderful journey so far. So what Dr. Sreeni, our scientific committee chairman, has done is basically incorporate each and every district ophthalmic society, right? Kasaragod to Trivandrum, the theme. And to top up that, our president, Dr. Arup Chakravarti's theme of controversies is basically what this conference is all about. Right from cataract to pediatric ophthalmology to retina to neuro-ophthalmology, everything is incorporated in this controversy series. So this is the fourth edition. We have much more to go, and involving all the district ophthalmic societies is a great act. On the other hand, we are also engaging with the common people. So we are giving total eye literacy to the people of Kerala by giving multiple programs, not only on the eye, but also on the other common social problems like COVID or like drug abuse or finance. So these are things that we as KSOS, being a socially committed organization, is coming up with. I hereby declare this CME inaugurated, and I also would like to thank Palakkad Ophthalmic Society, who took this upon the hand and into this course.
I think Gopal's internet is a bit unstable. Dr. Prashop, would you like to say something? Prashop? Prashop is our member scientific committee, and Dr. Thomas George and Dr. Sujit, we are moving together as a great team, and we are doing our best to do what is best for KSOS. I would just like to continue my welcome address. Professor Dr. Colonel Dr. Madan Deshpande, kindly agreed to give the Dr. Sihota memorial oration. Welcome, sir. And Dr. Sudeep has joined us. He is one of the most prolific cataract surgeons in India. Welcome, Dr. Sudeep. Yeah, Prashok. Prashok.
Yeah, sorry, sir, that is an internet issue. Yeah. So I would like to welcome all to this wonderful CME, and I think we're going to have a good time. Everybody's all geared up, and we are really awaiting the oration and setting the oration.
Yeah. Thank you, Prashok. I now request Dr. Rohan to represent Palakkad and give the, because I think Rajobal sir has not been able to join. So, Rohan, please.
Good morning, everyone. Jaydev sir could not join. He's trying it now. He's trying to get in. Okay, anyway, first of all, thank you for KSOS and the scientific committee. Am I audible?
Yes, Rohan, please.
Yeah, first of all, let me thank KSOS and the scientific committee team for giving me this wonderful opportunity. I've been honored to introduce my professor, Colonel Deshpande. He is more than a professor to me. Okay. Can I go ahead with the introduction?
No. Just we'll conclude the official inauguration session. You can do the vote of thanks, and then we'll go to the oration. So we'll start it by 8-10 minutes. At the earliest, we'll start. But just it's vote of thanks that you're supposed to do now. Okay.
Okay. Okay, I'm interested with the job of Rajobalan sir. I don't know, sir could not join in, but anyway, thank you for sir for sir is dot on time as our like FMC thing, no? Like sir will be there right on time. So thank you, sir, for joining us, and thank you, Sreeni, thank you, Gopal, and all of us who are watching. And thank you from myself and all the team from PSOS. Thank you.
Okay. Thank you, Rohan. So with this, we come to the end of our inauguration session. And next, we'll go to Colonel Dr. G.S. Sihota memorial oration. We are honored and privileged and lucky to have Colonel Dr. Madan Deshpande to be the person who will be delivering this oration. And Dr. Deshpande is Rohan's teacher, and he's really well known all over India in community ophthalmology circles and teaching circles and ophthalmology per se. Sir, huge lot of thanks for joining us and agreeing to deliver the oration. So we will go on to the oration session, and the chairman for this session is Dr. Jayadevan, and the moderator for this session will be Dr. Rama Venugopalan, and the convener will be Dr. Rohan. Jayadevan sir is one of the senior most ophthalmologists in Kerala, and has worked in Kerala Health Services for 3 decades as an ophthalmologist, and retired as a senior consultant and deputy director Health Services. He's one of the founder members of Palakkad Ophthalmic Society, and he was organizing committee chairman of Deshti 2007, which anyone who has been attending Deshti conferences over the years would definitely agree that one of the best Deshti conferences ever. Jayadevan sir, I request you to take over and conduct the session.
Thank you, Dr. Sreeni. Good morning, everybody. And now we shall start the session. Colonel Dr. G.S. Sihota oration. I request Dr. Rama Venugopal to introduce Dr. Sihota.
രമ മാഡം കയറിയില്ലേ? ആണോ? ഞാൻ പുതിയ ലിങ്ക് അയച്ചിട്ടുണ്ട്. Madam is he could not get in. He is trying now once more. Just 1 minute.
Okay, Jaydevan sir. And meanwhile, from your experience with Dr. Sihota, can you please put in a few words regarding Dr. Sihota?
I came to Palakkad district in 1983. At that time, there were only few ophthalmologists, and Dr. Sihota was the one of the first. I think he was the first ophthalmologist to start practice in Palakkad. And the thing is that he came from the northernmost part of India, Punjab, to the southernmost state of Kerala and started practice, ophthalmology practice. If I remember correctly, he was in Indian Army service, retired as colonel, and he had his post-graduation in ophthalmology from Vienna, I suppose. And his wife was Malayali, and so he could easily establish practice at Palakkad. And always the patients told the complaints to his wife, and he translated it to Dr. Sihota. And the thing is that in Palakkad, regarding our ophthalmic club, even from the formation, he was the patron, and he was with us for all the functions, and he was very kind, generous, and always encouraging us. And God has given him 100 years. He completed century, and till death he was active and healthy. That is regarding Dr. Sihota. Even though he was born in Punjab, he had become a Palakkad native, and his daughter, Dr. Ramanjit Sihota, of Art Center, Delhi, she is a expert in glaucoma, and because of she is the daughter of Dr. Sihota, we could get Dr. Ramanjit for many of our CMEs of the Palakkad Society of Ophthalmology. And we are very much interested to Dr. Sihota, and we pray his soul rest in peace.
Thank you, sir. And for me and Gopal, Dr. Ramanjit was a teacher at RP Center, a great person. And Madam, Rama Madam, do you have any slides on?
Just a brief introduction of Dr. Sihota.
Yeah.
Can you hear me?
Yeah. Yes, ma'am.
It's a brief introduction of Dr. Sihota. I think Dr. Jaydevan has done it properly.
Anything more to add, ma'am?
No, just fortune we had in associating ourselves with Dr. Ramanjit Sihota through him. He actually graduated from Ludhiana, his hometown medical college, took DO from London, and on returning joined army, retired as colonel. And though he was a non-Keralite, with the help of his wife, he could do great service to Palakkad, and it was proved by the number of patients he had till late in life, and he lived up to 100th year. That's something which a person can achieve in life. Active and practicing. Still a very few months earlier when he was not well. And then, of course, his daughter, Dr. Ramanjit Sihota, and the son has joined the army, is serving the army now. He was distinguished, soft-spoken, and a gentleman to the core. Our pranams to him. Thank you very much.
Thank you, ma'am. You can unshare.
Okay, now I invite Dr. Rohan to introduce our the speaker, who is doing the oration, Dr. Madan Deshpande. Dr. Rohan, please.
Thank you, Jaden sir. First of all, let me express my gratitude for KSOS and the scientific committee for entrusting me with the job. Actually, I am honored to introduce my professor, Colonel Madan Deshpande. He is more than a professor to me. And I don't think you will get a better person for this oration than sir, because sir has personally worked with Sihota sir, and also he is going to talk a topic which is close to his heart. I still remember the love for teaching. No, once he start taking class, he'll forget about the surrounding, whether it is day or night. He keeps on continuing, and somebody sitting has to tell, sir, 3 baj gaya, 4 baj gaya. So that was the love of teaching. So introducing my professor, I have made some few slides, but he has a big list of awards also. So I will share my screen now. Colonel Madan Deshpande is presently the Chief Medical Director of H.V. Desai Hospital, Pune, which is a high volume, high quality, comprehensive eye care hospital. The hospital has two more satellite centers as Nandapur and Jalgan, and they have performed more than 5 lakh surgeries, and the most of them, around 65%, is free of cost. He has passed the basic degree in 1964 and his MS in 1972, and joined the army, and he was there in the army from 1964 to 97. During this, he was actively involved in both the 1965 and 75 Indo-Pak War, and as well, and he was in the forefront with the infantry. He was earned a good name for dedicated service as well as a committed teacher for ophthalmology all over the country. Post-retirement from the army, he was head of ophthalmic departments of Bharatiya University, and then followed by H.V. Desai Hospital, Pune. He was a postgraduate teacher and examiner to various universities for the last 35 years. Postgraduate teacher and PG examiner to various universities, and examiner to PhD, AIMS and the RP Center, Delhi. Some of the awards is Visishta Seva Medal by the President of India in 1992 for the distinguished special and exemplary service of very high standard in eye care of the armed forces. Vishwamatra Foundation in 2006, Outstanding Service in the Prevention of Blindness Award by the Asia Pacific Academy of Ophthalmology, Bhusan, Korea in 2011. Best Teacher Award from the Maharashtra Ophthalmic Society, Lifetime Achievement Award from Pune Ophthalmic Society, Lifetime Achievement Award from the Marathwada Ophthalmic University, a Lifetime Achievement Award from the Association of Community Ophthalmology of India in 2014, Tamil Nadu Dr. G. Venkataswamy Community Ophthalmology Oration Award in 2015, and awarded Dr. Sri Ganesh Oration Award by Karnataka Ophthalmic Society for service to the society and contribution to the ophthalmic fraternity, and having served at the national level for community ophthalmology. He has done capacity building, strategic planning, and quality reviews of 32 partnered hospitals all across the country. Presently mentoring 12 eye hospitals from Gujarat, Andhra, Karnataka, MP, Maharashtra for quality, capacity, and streaming planning. He was president of Vision 2020, the Right to Sight, for the period from 2011 to 2015, and president of Association of Community Ophthalmology and of India and Maharashtra Ophthalmic Society. He has served as expert for appointing associate assistant professor UPSC in UPSC, associate professors in AIMS, New Delhi, has authored and presented a large number of papers in various conferences. Presently has credit of developing H.V. Desai Hospital in a quality service delivery, education, skill transfer, and research from 2 rooms to the present state. I have gone to the hospital. It's a big hospital, because as good as Aravind High Hospital. Forgived private public partnership with the government Maharashtra for ROP service in 5 districts. Member hospital in the west zone of Queen Elizabeth Diamond Jubilee Fund. Mentored government of Goa for establishing community diabetic retinopathy services, training ophthalmologists through skill transfer. He has been the chief architect in developing H.C. Desai Eye Hospital by technical input and advice. He has given an expert advice to rise a run and Kanta Lakshmi Shah Eye Hospital in the tribal belt, where they are doing more than 3,000 surgeries annually. He has also given technical support to starting Dharmasi Eye Hospital Center in Oman, Muscat. He has been a resource person in various NGOs, government and national level conference as president of Vision 2020, the Right to Sight in India. And lastly, he has been working for Agnihotra for healing atmosphere and equilibrium of the mind. He's such a multi-facet personality. And I am not you will be surprised to know that Sir knows each and every corner of Kerala more than most of the people, most of the people in this crowd. Thank you for coming, sir, and accepting our invitation and accepting for this oration. Thank you. Over to Jaydev, sir.
Rohan, unshare.
Yes, I invite Dr. Madan Deshpande for the oration.
Yeah. At the outset, please accept my greetings for this opportunity you have given to me. I am grateful to Sreeni, Gopal, Jaydevan, Madam Rima, and of course Rohan. Rohan is just like one of my sons and been with me for a very, very long time. Just because of his affection, and I think it's a great opportunity for me to have been selected to give a talk on Colonel Sihota. One minute. I'll share screen. Sorry. I'll again rejoin. No? Something wrong. Sorry for this problem. I just come back.
See, is there an issue with sharing?
I'm just sharing the screen. I'm just sharing the screen.
Sreeni.
Yeah.
Sreeni.
Yes, yes.
Can you hear me?
Yeah, I can hear.
Yeah. Dr. Ramanjit is online. She would like to just join. Is
Yeah, please.
okay?
Yeah.
Okay. Okay, then. Okay, so let's search after search.
I just
sir,
want to
sir.
see.
Is it okay?
Something is getting wrong.
Madam is here already, I think.
Sir, what we can do is, sir, you can unshare. Then you open your presentation, sir. Then once that is open, then you can share. In the meanwhile, let's hear from Ramanjit ma'am. Ma'am.
Ramanjit ma'am, we are very sorry to have troubled you in the last moment, but I couldn't resist myself.
It is a absolutely proud privilege to be sort of listening to Dr. Deshpande, who is a very old family friend. It's a pleasure to know that, you know, my father is being remembered. I mean, I can't thank you enough from the side of the family. Thank you. Thanks.
Yeah, ma'am. Like when we planned the meeting with Palakkad Ophthalmic Society, and I told them like they have a media meeting every year. I said it's not the regular KSOS scientific committee meeting; it's a special one. So we'll have an oration in Colonel Sihota's name. They said that's really good, and I think you did the first oration in sir's name, and thank you, ma'am, for coming in and putting in the word. Sorry for troubling you.
No. It is such a pleasure to listen to Dr. Deshpande in any case. I mean, as far as I'm concerned, he's Uncle Deshpande.
Thank you.
Sir, Deshpande, sir, is your presentation ready, sir?
I think Deshpande sir is now not
offline.
Meeting.
Rohan, ഒന്ന് വിളിക്കാവോ Rohan?
ഞാൻ വിളിക്കാം.
Ramanjit, ma'am.
Yes.
Yeah. See, while sir gets back online, see what do you feel about the ophthalmology training in India per se? Like, not the big centers. You have a lot of DNP courses going on. See, that's why I thought we'll have a session on ophthalmic education, because see, I mean, you can say it. There can be controversies in it, because many of these centers, when the kids come out, I mean, they don't have even the basic training. And I asked Sir Colonel Deshpande, sir, so can we actually put a number for the training? Like when these kids come out, this many number of surgeries, this many number of surgeries. So he said maybe it might be putting a lot of pressure on the centers, but should there be a guideline on the training part as such?
See, what I feel is that the surgeries somehow, I think the students themselves push and try and get as many as they can. But what is, I think, lacking is the teaching of skills. So they know the theory, they know how to pass an exam, but skills in terms of, you know, doing, say, I mean, I'll talk to you on behalf of glaucoma, but you know, to be able to look at a good sort of retinal examination, is there anything in the macula, is there anything on the disc, to do a gonioscopy, to do a good slit lamp examination. Even these things sometimes are not actually being taught. They are actually used as stenos and, clerks and things like that more than actually being taught. The other thing is that, if they were actually supposed to keep a case book, you say that anterior segment, they should have actually followed up one cataract case or two cataract cases, one case of corneal ulcer, one case of the common things that we are likely to see, then they would be actually forced and would also know what happens in the long term. Okay, the patient comes to you today, you're treating, so they say the corneal ulcer, and you have no idea how it progresses from there. I think sir is now ready, but I think there's a huge iniquity in the education, ophthalmic education, and the DNV especially. It's a toss-up as to where they end up. So there are certain centers which are very good and certain centers where they're not even taught anything. So if they were to have a case book or, some sort of record of how many applanations have been done, how many sort of fundus have been seen, these are probably also things that make a huge difference in the long term. Surgeries, you're right, we should have a minimum of cataract surgeries, some amount of extraocular surgeries, but beyond that, I think it's very hard to put numbers.
Yeah, totally agree, ma'am. Like, when I came out of RP center, probably I might have done about 70, 80 cataract surgery, and 2 years and I did 25,000. So, but see, whatever my teachers taught me in RP center, like Dr. Garg catches your collar and pulls you and does this. See, still, even now when I see the patients, see whatever was discussed in the rounds and in the classes, it comes back, because I didn't have a very happy time in RP center, because it was a big struggle for me with Dr. Lalit as my co-guide and all. It was Gopal will say, but see, you come out of a teaching process like that. It's not the surgery numbers. It's, as you said, the basic training that you get, the clinical examination. That is what makes you. So, totally agree with you, ma'am. Deshpande sir, see, even if you have a problem with your screen sharing, I don't think you actually need a presentation to.
Yes, sir. I'm just trying to. I don't know whether.
That's okay, sir. That's okay, sir. Wrong. See, without a slide, also, I'm sure that you can.
I can.
A lot.
Yes, okay.
Teach us a
Okay,
lot.
Let me. I'm sorry for this matter.
No, that's okay, sir. You can unshare your screen, and so that you will be there.
Yes. Unshare. Can I stop sharing?
Yeah.
Okay.
So you please, sir.
At the outset, I feel very elated. Am I audible?
Yes, sir. Yes, sir.
Yes, sir. At the outset, I'm very much elated to have been selected for this great person, oration. Dr. Sihota was my guru, was my mentor, and more than mentor, he shaped my career. Dr. Sihota was a perfect eye surgeon. He was a hard task master. He was a perfectionist. In the army, he was a senior advisor controlling the whole ophthalmology services of the Indian Army. I've seen him since 1971. At that time, before I joined him, as a sort of a, in Army, there's a system, whatever you have done outside, whether you have got a foreign degree or a home degree or from any university, you have to undergo 3 months sort of a observation. And then he used to select whether the person would be beneficial to Army, would be able to do justice to specialty or not. And he had a courage of conviction. He would call a spade a spade. A person who would do well, he would select. A person not doing well, despite sort of any recommendations, he would not hit you. I went to him, I remember, first day, and he's a great personality. He had to look at me, looked on me, and he said, "What have you done?" I had a pride that I had done my MS and DOMS. So I told sir, I had done MS, DOMS. I still remember what he said. I don't care what your collected fancy degrees from some university. I want to know what you are today. That's what is more important. What we got degree is not important, but what we have got, our skills, what knowledge that is important. That time I must have felt hurt, but down the line, memory line, I feel. Then he called me, asked me some questions. I was very good in theory, said you are good. Asked me to see the slit lamp. And those days in 1970 and all, slit lamps and all were not available in many places. And we also had a very one or two looks at that. So I told sir, I don't know anything. You teach me. He said, okay, I'll teach you. In 3 months, he taught me. And then he had a sort of a, I have to sometimes I'll talk in detail about him. So he asked me, and then he had a sort of a arrangement that whenever you had to remove some eyeball of a patient who would like to sit, I'm asking to sit down. Then explain him. And similarly, when you used to have failed somebody, he used to ask him to sit down. So after 3 months, when I went to him, he asked me to sit down. I know what was coming to me. So I said, sir, sorry, sir, I'm not going to sit down. I would like to stand up and be with you. He said, you're a half-cooked meat. I said, that's not my fault. You cooked me then. Then, am I audible?
Yes, sir. Yes, sir.
So he said, fine. Then he got me posted in Army Hospital under him. And that was the most golden period of my life. I learned ophthalmology, basics, and till today, whatever I am grateful. Sihota, those days, as Ramanjit has told me, told you all people, he was a specialist of all specialties of it. He used to do retina, he used to do lid reconstruction, he would like to do cataract. Those days I was not there, so of course he was not doing it, but everything in eyes he used to do. Meticulous.
There is some problem with the net also. Net connection, there is some issue.
Rohan on the sample. Dr. Sudeep. Sudeep is there?
Yes, I'm there.
Yeah, I mean, in the meanwhile, you have been a prolific teacher for so many cataract surgeons. See, what do you actually feel like? The stage at which they come to you, and for a teacher, a surgical training teacher, do you really assess if somebody is really trainable or everyone is trainable?
Well, I think majority comes somewhere in the middle. I mean, some are exceptionally good, who you know that they will pick up very fast. And there are fortunately only a few who I realize are untrainable. I mean, they're probably better doing a non-surgical specialty, but that number is very few. So most come in the middle. So given enough opportunity and time and let's say, when I say time, it just doesn't mean in the operation theater. So basically I would get them all to record the surgeries, come and meet me after that. And very often, of course, they would go up to a certain point, then one has to take over. But it takes a lot of time. Yes, it takes a lot of time, a lot of patience to do that. And I know that some who have struggled at the beginning are now fantastic surgeons. I mean, they're not just doing ordinary cataracts, they're doing complex cataracts, they're doing secondary ails, they're doing all sorts of things. So yes, but it needs that time. But unfortunately, I wish we had a postgraduate program everywhere, MD, whatever, MS, MD, whatever, where they came out at least with some basic skills. Majority seem to come out from medical colleges knowing nothing at all about surgery. Or that is the sad part. I mean, we could pick up from that point and make them better, but then we are starting from the rock bottom.
It's quite a lot to ask for, Dr. Sudeep. But as Dr. Ramanjit rightly said, see, if they have, if you train them to have, yes, sir, yes, sir, yes, sir. You're back, sir. Continue, sir, please.
So, he used to go, he would with 3 mirrors, gonioscope, he would find out the holes and ask us to go and have a look at it. And a method, direct method of teaching. And he was very, very meticulous. Then I remember those days, foreign bodies in the eye, he used to ask us to get X-ray, the nimble ring, and he want to have perfect sort of a straight line against it. We used to we'll go day and night. Those were the days. He wanted that all case sheets had to be written. All patients have been seen who are admitted in the morning or in the night before he came to the office at 8 o'clock. And dressings have. So when he entered his office, immediately he would enter and give the report. It's a direct method of teaching. We didn't have to learn much. I'm telling you, read books much because we saw the evolution of the disease. Whenever we saw a case during call duty, either a case of a papilla edema or a sort of anything, he would ask us after 8 days, what happened to that case? And if we had not seen it, reviewed that case again and again, we had it. So we saw the evolution of disease. In all cases of ophthalmology, whatever we had, huge experiences, a lot of cases. So it made us, our knowledge is sort of evidence-based, it made our knowledge sort of a lifelong remembrance. So I didn't have to read much, believe me. Similarly, he had taught us so fundamental so well that even if a case came for a simple fundus examination, Colonel Sihota would like to know what other problems are in the case. So I remember an incident where a child came, and when the child came with ataxia, he had just come for a simple fundus examination. I could have seen fundus, said normal, and the child would have gone. But the moment I saw ataxia, and as his practice of seeing case as a whole, I saw the child, I found the KF ring, wrote down. I was a very young junior major at that time, and the neurologist came and asked, who is this new joker come, writing, KF ring and all. Then Colonel Sihota said, if you have seen it, yes, written it. You don't have to ask me. He has so much of faith in his juniors. He made them work, gave them knowledge, and also empowered us. And believed in us that whatever we do, I think that's the right way of a teacher, that we teach hard way, teach right way, empower them, and believe in them. I remember this Sihota or old Vedic tradition. Whenever we used to have the sort of a learning those days, they say Athato Brahma Jignasa. Whenever somebody wanted to learn something, they had to go to a guru. What should the guru he should do? They say he should be Gache Samit Pani Sotriya Brahmani. That man should have a good knowledge of theory, he should have a good knowledge of practice. That is the real guru you should surrender to learn. How do you learn? Like these days, you want to please your guru, you do so many good things, take him to party, please him, be around him. But in those days, they say, how do you serve your teacher? They say, Pariprashnena Sevaya. Go and ask him a question. Go and ask him your doubts. Clear them. Till such time a stage comes, there are no doubts, and a stage comes, they say, Gurostu Maunam Shishyastu Chinna Samsaya. You go to a guru, you're agitated, you don't know a problem, you want to know the answer, and he just keeps quiet in front of you, you get answer. That means knowing the heart, knowing the sort of a establishing sort of that relation that you get involved, you start knowing yourself. Then one more thing they say was what now we should all learn, and the students must learn, that Nirlajjo Guru Sannidho. That means you should not hesitate to ask questions. Those who hesitate, those who have got an ego, they don't learn. Same as Sihota was, whenever he made a mistake, he used to come and tell him. You are the hard taskmaster, you have taken for a task, but one thing I tell you, I've never had a fear in my mind to approach him. Anything I made mistake or anything I think, I would enter his room, and talk to him. There's another shouting, but I learned. I learned a thing. He also needs, and the amount of affection he has got was tremendous. So that's all about Colonel Sihota, who made the life of us for everybody. Now coming to present day teaching. Now present day teaching, we have now a lot of problems in the sense there's enough they've got a good sort of a program. Curriculum is there, syllabus is there, meticulously planned. But what happens, normally in any sort of establishment, 65% of the teaching goes in the government sort of a setup. In a government, the teachers, are not the main problem that has happened in the whole teaching assignment is teaching is a byproduct. We have peculiar job at a national level and a local level that is reducing the kindness. So in view of that, that ensure ourselves that our services go beyond sort of a doctor-patient, like a shop thing, patient comes to you, operate and finish the whole thing. No. That to ensure that we reach the community, ensure that we reach to them, and ensure that the avoidable blindness is reduced. In that process, what happens, these tasks are also given to medical colleges, these tasks are also given to private practitioners. Everybody is joining in that. As a result, the teaching has become a secondary thing. You are busy in your own affairs. And teaching also is not budgeted for. Government probably is budgeted, there are professors, there are assistant professors, there is a hierarchy, and then there is money allotted. But as far as the NGOs are concerned and other countries, not budgeted. Then in government, we found that we did a strategic plan for the one of the states, that is Madhya Pradesh. We found, unfortunately, that a person joins as an ophthalmologist. He's not put in a job of ophthalmologist, and he serves as a general person doing postmortems and this duty and that duty, administration. And after about 6 or 7 years, they wake up and they say, "Oh, that fellow is ophthalmologist, put him on a job." By then, they make sure that he forgot everything. And at the fag end of his career, before he wants to retire, he wants to resettle in life, they send him for a training in cataract surgery. Imagine all of us have seen what happens. An elderly person coming and trying to attempt to do a SICS or a FACO, a lot of problems come. Then they are given other stuff. So teaching is not a primary aim. So there has to be planning, has to be done at a national level. I feel that there has to be advocacy, has to be done. The teaching cadre has to be a teaching cadre, well planned. Then there should be sort of a time allotted to them. Now, what happens normally, we all see that there are 3 things in the teaching. One, didactic lectures. Then there are sort of a case presentation of what we call grand rounds. Then there are the journal club and other activities. And of course, we keep on learning by shadowing the consultant. Now, in didactic lectures, the poor person who is going to give lectures early in the morning, he comes, half sleep, half this thing, he has hurriedly made his lecture. He gives the lecture sincerely or not sincerely, whatever it is. Whereas students of them, they have got some other thing going in their mind because they have to prepare a case which they are not prepared and they're going to get a bashing from the boss. They are not attentive at all, most of them. Then as far as the grand rounds are concerned, mostly grand rounds are done by consultants. He's an expert in that field. Most of the students are sitting with the AO and wonder, what's he talking? We want to teach students because unless they open their mouth, unless they fail, unless they know what is their gap, they would not remember. So it has to be the other way around. Let the student, then secondly, other also we have to have in FMG, I found most of the time, a student would present a case. When he is presenting case, others used to be, just sitting there enjoying because that fellow is presenting, he has read everything. So I made a practice that I never asked the person who presented the case, I asked the others. I said, you must know all about it, not the person who is presenting. Similarly, what happens, normally we give a case, he prepares everything, he asks his friends, he asks his professors and all, and then he presents. Now, then they lose that practice of finding themselves what is the problem in the case. We used to often have, I used to call them and see what is the issue and see. Let me know what it is. So give them impromptu because in examination, You give them a case impromptu. And the fellow doesn't know because his habit is that he knows the case, he has prepared for the books, and he presents it. They have never given a chance to present the case impromptu. So this practice has to be there to give them a case, let them in front of you examine, let in front of you tell what is it, then only they will fare well in examination. Of course, nowadays everybody does well in examination, that is a different story. Because in our days, we say, we never say we passed MS, we say MS has been given to me. And so that is the practice, they say that is the etiquette, that you can never pass any examination that is given to you. Similarly, today also, if you do introspection, most of the time it is given. I'm not trying to ridicule all the students who are doing practice and all, who are doing a lot of hard work. Many of them they get it, many they deserve it, but still it can be better. Then talking about the skills, majority they have done a lot of studies, a lot of papers are published about procedures. Now, what has happened that the main thing that ophthalmologist was the expert in it initially is to do the refraction. But nowadays, they don't know it. They don't want to practice it. Yes, good. We have got different cadre, a technical person to do technical job, and they should devote themselves to the ophthalmic sciences, and refraction should be relegated to a refraction is fine, no problem, optometrist. But one should know the art because you're supposed to supervise him. You're supposed to sign what refraction has done it. You're not supposed to sign independently. So in that case, art of refraction must be inculcated, must be taught. If they did not practice it, but they must know it. Similarly, for the other than slit lamp and 90D, many people they do it. Many places they nowadays it become compulsory. I find nice thing now people are doing it. We should make it compulsory that first 3 months of the training. 2 things I made compulsory, and I feel that people should do that. All postgraduates must handle all equipment, diagnostic equipment, so that they learn, and particularly indirect ophthalmology. Because unless you know indirect ophthalmology, nowadays, of course, a lot of things can be done by 90D and 70D, but those days, indirect ophthalmology today also is important. So when they know these equipment, the diagnostic skills become better. And second thing we showed was, whenever a question was asked, they should talk, don't hesitate. I remember one incident, one of the colleague of Rohan, when we asked a question and they say, like that normal thing. I said, I want you to answer sense or nonsense. I don't care, but respond. Learn to respond. Automatically, sense will come out of it. So these are the sort of things they should do. Now, the other diagnostic procedures are done by paramedicals. And what happens, that most of the postgraduates do not bother to know how to start that machine, how to do it. They interpret it nicely, good. Even the consultants also do not know how to. Many a times it happens that my paramedical has not come. Sorry, I can't operate the machine. You can come tomorrow. This happens. All of us, I would tell you, big setups like corporates and NGO hospitals, we all depend upon our family. Good. But at the same time, we must also know it. And the worst thing is OT procedures. In OT, right from the sterilization techniques and what are the autoclave techniques, one must know what are the standards. Because all procedures, professor doesn't teach. Assistant professor doesn't teach. They are taught by the senior residents to the junior residents. And over the time, what happens is they get diluted because various people come from various other institutions. Some practices are there, they're not uniform. You'll find that ultimately one day you're shocked to see that originally what you're taught is not there and people are practicing something else. So in between, if not regularly, one has to go into the details. What is happening? What are procedures people are following? How they are doing it? Because you're supposed to be done under observation, an observation of an expert. That's most important. So we have to devote time. Teaching cannot be a byproduct. Teaching has to be a serious business. It has to be sort of a right. It has to be time allotted, and they should not do anything else when they are teaching. Then comes the surgical skills. Now, many places, I feel even the case presentation is virtual because they're not allowed particularly in a private hospital, to see a private patient. So they learn theoretically. Case presentation also, they from the case sheet, they take out the sort of what are the problems with the patient history and findings, and then present. There's no patient. That way, one will not learn anything unless you are that patient-doctor relationship has to be established, and that can only establish not virtually. It can only establish when you are dealing with a patient. There's so many things you have to do. Not only a patient doesn't have only eye. There's a body. There's a mind. He has to have faith in you. So all these things has to be seen properly. And about the skill set, what is normally done, we have found a lot of papers again say that what is practiced in the society today is not taught to them. What is taught to them? Probably few SICS skills. Number is not uniform. The exposure is to SICS, and they say always you have to do some fellowship to learn. They could not at the fag end of their 3 years, they're exposed to things. The present load, I believe, is about MS is about 935 in 123 colleges, and around 135 or so about DND students, and equal number of fellows. These all the people come for training. So training is a sort of a serious issue. Then what is happening is still, people learn and they make a lot of mistakes because suddenly they are taught on the patient, and step by step we give them surgery, hand holding and all. Good. Many people learn. Then nowadays the good asset is there. We have a sort of take the head of wet or dry labs. Wet labs is a problem because we get the eyes from the goat's eye or sort of a pig's eye, and there's always a chance of infection because same residency is done to the OT. So it's preferable that at least we have what we have done. If we have the Kitaro set is good. We can use one eye for 5 to 6 times, and they learn quite a lot. Then coupled with that, what we did was there's a cyber-side program where you can assess each step, rubrics, and numbering them. So one should. You also know before he comes for the training, you have a sort of find out what is his knowledge level before he comes, so that at the takeoff level, what is he, and at the last, what is he. So that is more important than theoretical things about TCC, about the wound. He has to read, pass from cyber-side the program, that unless he completes the questions, he cannot go to the other step. So step by step, he learns the theory, also the practice. Then he practices on sort of a Kitaro for 6, 7, 10 times, and then they switch on to the patient mode. Initially, we saw not many complications. That's the single reason many places, the postgraduates do not get start very late in doing surgery. I would say myself that if you teach them well, they're an asset to organize. Now set up, right from second year, third year, they're a great asset, and they do quite a lot of surgical work as you are how to do clinical work. So teach them early. Teach them early so that they are usefully can be employed by the organization. So that's about the then other thing that is coming, and that has reduced the complication to a very, 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 very drastic level by just make a difference in wet lab, cyber-side program, Azure Kitaro, and evaluation. Because once you evaluate, and then he sees his own surgical sort of recordings, what has he done, what mistakes he had done, under the guidance of the sort of observer, and then because they have tendency to themselves. If they start doing themselves, they again will make a mistake. So there has to be perforce, some observer who knows the science of surgery, and he can teach them, guide them. Then another thing that is coming, evolution from good to the postgraduates, is simulation. Simulation has come for the SICS. Tomorrow we may have simulation for the FACO also. We also have received simulation for the glaucoma surgery. So this can be a great step. Simulation is also now available in US and all for the vitreoretina surgery. And very soon, this is a big step. Like, in Air Force also, a pilot, when you want to learn the art of piloting, they have to put on simulation. And then they become best pilots. Similarly, we have in future, definitely we have sort of these things will come But whatever you may be, whatever you can do of patient learning, you have to learn on the patient. And for that, you have to have all the sort of a method of right from manner of basic care. You have to treat him as a person, respect the patient. There are so many things that are already given the procedure for a person learns. So teaching has to be a serious issue. It has to be budgeted, because if you see that a postgraduate, when he stays with you, they say in UK, he's supposed to do about 350 to 500 surgeries in 7 years program. In USA, I believe he's supposed to do 84 to 120 surgeries in 2 years, 3 years time. In India, it ranges from 50 or 5 to 1,500. Even if you consider that in India, if he's supposed to do about 750 or 800 surgeries, the cost, if you find out, 800 into 3,500 surgeries, it becomes sort of more than 27 lakh rupees. Then the stipend to DNB students goes to under about 27 lakh rupees. So in an average, one has to spend 1 crore rupees on a postgraduate institution. Like DNB I'm talking about. MS and all, they're lucky because government spends money on them. It's surprising that the patient, the student getting 10 marks less, he lands to do DNB, and a person getting 10 marks more, he goes to do MS. Everything is free for him. And 10 marks less, everything is not free for him. It's a burden on the organizations like NGOs. Yes, spending good. We are happy that we are spending on it, but government has to rethink on all these issues, because that's why I say we have to advocacy at a higher level, national level. Because third point I would like to stress before I close is not a surgeon alone, is not a student alone. We need to be taught, because what happens normally, we all know when we were students and when we are teachers, when we are professors, we're in a hurry to finish the job. And students normally get to operate at the last fag end of the surgical day, when with a substandard equipment, substandard instruments, and substandard team. That should not happen. We change. Start in the morning when they're fresh. Make a OT, separate OT for them. Give them a chance to operate. Give them the best equipment. Because with a bad equipment, they will do bad surgery, and then they will be inhibited to do better. There's one. Secondly, we also need to train the team, because it's not a surgeon alone who can do wonders, unless you have got a team which can be trained, and refresher has to be there, because we have no standard training for paramedicals working in the operation theater. Skills in the diagnostic skills, we are doing it. We are training optometrists to do that, but it's not formal certification is not there. So all these areas we need to train them and to have some sort of a national standard, national level sort of a policy for OT assistants, for diagnostic sort of paramedicals like perimetry, SA, photography. It's not done by ophthalmics. They're all done by paramedicals. But there has to be some standardization, some sort of a training, some sort of a refresher. Army, we have a very good system that once, what happens, once we become associate professor or assistant professor, become a professor, there's nothing, no training. You become a boss, then whatever we say, you become, complacent. In Army, the system is you are a graded surgeon first. After 5 years, again, you have to classify somebody, you have to go to your advisor, then he observes you for a month and makes you whether you are fit to become classified or not. And then again, there is another stage of becoming advisor. So there has to be stages, because profession ego should not come in. Our skill set, our knowledge set has to always, like there's a licensing system somewhere. We all shout, if that comes in because you're encroaching on our this thing, you're doubting our policy. But at least you should have self-control, self-learning. Of course, we learn through all these seminars, webinars and all, or there has to be some sort of a policy, something like that. So I'm happy that I'm sorry for making a mess of everything. I could not, because I'm not techno-savvy. I should have been. And there's one example that I depended on somebody to do that. Today being a Sunday, I could not do it. I'm so sorry. You'll excuse me. But I'm grateful. I could talk about my boss. I could do his puja in a better way. And believe me, there's a great man. and whatever I could give to my students all over because of KSOS. I'm thankful to you for Kerala Society, Dr. Sreeni, Dr. Rohan and others for listening to me, Dr. Everybody. Thank you, sir. And of course, I am thankful to Dr. Ramanjit for being with us. My namaskar to Madam. Sorry, sorry, that message could not. I was last step of sharing the thing. I could not do that. I'm sorry.
Sir,
Thank you, sir.
You don't require a PowerPoint presentation to make an effective presentation, sir. Probably it was best that the PowerPoint was not there because everything came out in a flow from you. And see, probably, I mean, not probably, I will definitely share your talk with Dr. Namrata. See, I know that she's doing her bit for ophthalmic education in India, but your feedback would be great. They're going to have a governing council meeting soon, probably on 16th. I'll send you a video or share your suggestions with her so that there can be a movement on advocacy on ophthalmic education in India. That is, I mean, really required. Ramanjit ma'am, any last words from you, and then Jayadevan sir can conclude. Ma'am, if you're there.
Yeah. What I'd like to say is that I think sir has actually put together all our points, and what we need to do is to actually get a standardized curriculum. And I think the MCI tried for many years, but hopefully Namrata in her enthusiasm and her push will try and get it together, because we had actually discussed this. And I think this is something that is a felt need. If we can actually define what the skills should be, define exactly the common sort of problems we see in India, then I think we'll have gone a long way towards making our patients safer and our doctors much more competent. Thank you.
Okay, thank you. Thank you, Dr. Deshpande sir, for coming for this program and sharing your experiences. We are extremely grateful to you, sir. If there are any comments, can have it.
The only thing is the tragedy that if teachers to find time to teach, and if this is the burden, that's the tragedy of education. No, he should, that's why it was the teacher's business. The teacher should be given a time, which is a cadre, serious cadre. Of course, the other sciences should join, but teacher should be a teacher, doing also clinical work, because that's where you learn.
Yes, sir.
Thank you, sir. Thanks a lot. Thanks a lot for joining us and for the oration. It was a wonderful
I
oration.
for not making the right presentation.
No, it was great to know you. I mean, thanks, Rohan.
Yeah.
Me too. And when it's a privilege to know. Thank you, sir. Thank you, Rohan. Thank you, Jayadevan sir, Rama madam, Rohan. Now we'll go to the next session.
Thank you, sir.
So this will be on controversies and cataract surgery. So the session, I request Dr. Mridula to introduce the speakers and convene the session. Dr. Mridula is one of the most prolific cataract and refractive surgeons in Kerala, and she finished her DNB from Arvind Madurai and worked in UK for 3 years. Did her FRCS from both Glasgow and Edinburgh, and started practice in Palakkad at Trinity Eye Hospital since year 2000. and she's definitely a real high volume phaco and refractive surgeon, and she's the chief medical officer of Trinity Group of eye hospitals with about 7 branches in India. Dr. Mridula, please take over.
Thank you. Can you hear me?
Yeah.
Yeah, thank you, Sreeni, for the wonderful introduction. I'm really honored to be here for this session, which is the controversies in cataract. And I'm really honored to introduce one of the eminent, most experienced doctor, Dr. Minu Mathan, who is a friend of mine. And we were together in Aravind, Madurai. And he's a very high volume cataract surgeon associated with Chaitanya Hospital, Trivandrum. Highly skilled, innovative. He makes his presence very noticeable by his high sense of humor and an innovative technique. He's the chairman of the session. I welcome you, Minu, for the session. And going to the panelists, Dr. Chitra ma'am, another wonderful person, well known to everybody in ophthalmic fraternity. She's a medical director of Eye Foundation Hospitals, which has got more than 12 chain of hospitals in South India. And she's currently the chairman of Academic Research Committee, AOS, and managing committee member of TNOA, and very highly proficient cataract and refractive surgeon. And I always remember her with a bubbly nature, always smiling. On behalf of PSOS and KSOS, I welcome you, ma'am. Next, Dr. Elankumaran, yet another eminent phaco surgeon and refractive surgeon, who's a medical director of Navashakti Netralaya. He's a vice president of Bangalore Ophthalmic Society and treasurer of Karnataka Ophthalmic Society. A very friendly person. I know him because he had come for one of our conferences conducted by Trinity, Tricon. I welcome you, Doctor. Dr. Sudeep. Dr. Sudeep Das, who's currently medical director and CMO of Shankara Eye Hospital, Odisha. He was previously a senior consultant in cataract and refractive services in Naran Netralaya. And that is when I happened to see his surgeries. You know, like he is an excellent phaco surgeon and handles all kinds of complicated cataract surgeries. And on behalf of PSOS and KSOS, I welcome you, Dr. Sudeep. Dr. Naveen Gopal, I don't know him personally, but yesterday, Sreeni was talking a lot about you. He was telling he's a very enthusiastic and a very innovative surgeon. And he's currently the director of Gopal Netralaya, Bangalore. He was heading the Vasan Eye Care Centers in Bangalore previously. He's a cataract and refractive surgeon, and he's completed more than 20,000 surgeries. And I welcome you, Doctor. Over to you, Minu, to head the session.
Okay, so did I stop screen share?
Yeah. There is no screen share now.
No screen now. Okay, so welcome everyone. This session is going to be very interesting with all our very eminent and experienced panelists regarding controversies in cataract surgery. We have 1 hour, and we have tried to cover a few topics which are of interest to all practicing ophthalmologists. And this is not supposed to be a debate. So this is not going to be saying something against it or for the sake of debating. This is for giving take-home messages for practical use for all practicing surgeons. So with this, we will move on. Welcome all the panelists to this. We have timed and arranged some topics so that we'll get crisp answers and we'll finally sum up everything after each topic. So to begin with, we'll start off with biometry. When we do biometry, we know that's very important because whatever surgery you do, and if it is going to be a wrong IOL power or astigmatism, patients are going to be unsatisfied. So what kind of, it is true that we may have basic units or some may have very advanced units for biometry, but still most of them work for what practice they have. And so what is your preference of biometry, provided you have some advanced versions also. And the time. See, I know that there are centers where patients come in the morning and they get operated in the evening. There are patients who, there are places where they come in the morning and they get workup done on the same day, and they come again for another workup, and then they get operated on another day. Everybody has their own reasons for that. So I would invite Dr. Elan for your preferences on the biometry and the timing of it.
Thank you, Dr. Minu. At the outset, I'd like to thank KSOS and PSOS for giving me this opportunity. All the office bearers, thanks a lot. We are starting with biometry, the basics of cataract surgery. All of us started with ultrasound biometry. That's what we could afford. And now we have gone to optical biometers, and among optical biometers, the SS-based ones. So first, we'll talk about the machine, which is better. As regards the machine, whatever you can afford is better. But if you can afford the highest, then I would prefer to go with the SS optical biometer. There are 3 variants available in the world as of now: IOL Master 700, Argus, I think it's coming to India now, and then Tomy OA 2000. These are the 3 SS-based optical biometers available in the world. The advantage with an optical biometer is the second part of the biometry is the man that is involved with the biometry. Even with ultrasound biometry, we used to get very good results, particularly with the immersion one, if we were to do it. But if a young optometrist was doing it, we were getting surprises. The advantage with optical biometry is it removes that man component there to a major extent. That's number 1. Number 2, it can help with the newer formulas. They are incorporated into the machine, which is not there in an ultrasound biometer. That's why I prefer this. As regards the formula and as regards the penetration, the SS-based ones are very good. Very, very few, maybe around 2 to 3% of it, we don't do a ultrasound biometry. We do an ultrasound biometry, the need for ultrasound biometry. Otherwise, almost 98% is covered. As regards the formula, the earlier formula, the earlier formulas have been completely almost given up, to the extent that we use the fifth generation formulas now, of which my particular preference is Barrett Universal, for the simple reason it's a universal across all axial lengths. Normal axial length, any formula would do, but across all axial length, these are the formulas that I prefer. This is as regards the timing, what you asked. Closer to the surgery, better it is, but I would definitely not do it on the day of surgery, at least a couple of days earlier. And then how old can it be? There have been studies that have shown even up to 2 years, you can accept a biometry in an adult, but this doesn't hold good for when you're doing a pediatric cataract.
Thank you, Elan. So to add on, Dr. Naveen, please.
Thank you, Dr. Mathan, for including me in this prestigious conversation of KSOS. My take is slightly different than Dr. Elan. I completely agree with Dr. Elan. SS source biometry is definitely the gold standard. But for a single practitioner like me who can't afford 20-25 lakhs, I still now prefer ultrasound biometry. But the small changes, what I do with my practices, I have 2 machines, 2 A-scan machines. One is Ecorol Pro and one is Keeler. And I do for every patient, for every eye, 1 machine on contact and 1 machine in immersion, and both has to correlate. And by OCT, which is a SD source, can also give me an axial length if at all, if there is any controversies between these 2 readings. That is how I do my A-scan readings. On all, I do it myself because my load is not as much as I used to have in my corporate practice. Now maybe I do 4 or 5, so I am able to manage to do by myself. But if it goes out of my hand, definitely sub source A-scan is definitely better than the the ultrasound method. I do agree with Dr. Elan. This is my take on it. And regarding the timing, I don't prefer to do A-scan on the same day of the surgery. I always prefer to do at least a day before the surgery. And if there is a difference of 1 diopter between the 2 eyes, I would always like to repeat the A-scan in either of these 2 machines. This is my take on it. Thank you.
Thank you, Dr. Naveen. So we will sum it up as The Society based ones are the best, but if you don't have access to that, the ultrasound immersion works equally well if done with a well experienced technician. And contact, I don't think should be taken as a single machine which can be your sole machine. So ultrasound is fine with immersion being there to always back up for your contact. And the timing on the day of surgery, maybe if it is a fresh case when they come, the first thing you do, if you do biometry, then you most probably will get a good readings, but not after doing too many investigations and putting drops and dilating and all those things. So we'll move on. We'll move on to the next topic. Is many patients of ours are diabetic, and many of them are on blood thinners. So some cases we do SICS, some cases we do phaco. See, I have chosen the panel which consists of single practitioners, people who have been in corporate practice, in charitable organizations, been in government practice, and bigger private institutes. So this will be a mixture of experience of all these people. So diabetes, it's always dicey. When do you want to control? How much do you want to control? And what is the criteria you take? And what all do you stop and not stop? We may do topical, we may do under block, we may do SICS. What are your considerations? Dr. Sudeep, first, please.
Yeah, diabetic, the amount of control is always controversial. I don't think there are any guidelines also, either whether in India or in the West. So I prefer them to be controlled. At least I would want a physician or a diabetologist to say that they are controlled. But the absolute limit is controversial because what are you going to do? I mean, the cataract is progressing. They're never really going to come under about 200 or whatever. So it probably just depend on the physician. But if I'm doing at a fairly high level, I would want to take a separate consent from the patient also, a high-risk consent for whatever it's worth. But I would go ahead. Topical or not, I would always prefer to do phaco, of course, especially in a diabetic who is slightly higher and probably on blood thinners and other things. They have multiple issues, not just diabetic. So if it's a phaco, then I'm not bothered whether they are on any sort of blood thinner or whatever. I would not prefer to do it topical because if you're going to give them an injection, again, the more chances of getting a bleed there. And I had a patient when on Naranethralaya where, when they opened this was an SICS, thinners had been stopped. But then that to stop thinners for 4 days, 5 days, nothing really happens. The cardiologist would tell them to stop the thinner for 5 days, nothing really happens. So the whole eyeball wasn't visible. It was caked with the blood clot. And the PG was horrified because she was wondering what happened to the eyeball. She couldn't see the eyeball at all. It was under the clot. And then we had to actually send her to MS Ramaya and the bleeding was still continuing the next day. So yes, preferably phaco. Even if it's a lower package, it doesn't matter, but preferably phaco because then you don't have. But then a lot of these people will not dilate. They'll end up with a very small pupil. And it's not possible for everyone to do all these manipulations under topical. So then one has to give a perivalvular block if necessary, and then go ahead, or at least if you're confident, then of course you can use intracameral xylocaine and go ahead with the surgery. But preferably topical, preferably not stop anything because I'm more worried about people having cardiac problems when you stop all these other drugs that they're on, multiple drugs that they are on.
Okay. Thank you, Sudeep. We move on to Dr. Chitra, please.
Without elaborating on what Dr. Sudeep already said, I think it's important that there should be a good diabetic control, and probably the best way to do it is to check the HbA1c, which will give you an impression of how the blood sugar control was over the last 3 months. And that should encourage us to take the patient, even if the patient is supposing borderline 200 or something in the pre-operative morning evaluation before the surgery. Because of stress, it could have gone up. But excepting for that situation, if you can plan and do a good surgery, definitely a diabetic patient without poor blood sugar control is more immune compromised. And if there are going to be any surgical complications or challenges, the response of the eye is going to be very, very different. So I would advise a significant diabetic control, and the best way to do it is to check the HbA1c.
Just
and
one
madam,
thing I'd
in
add.
SICS cases, do you suggest?
Just one thing about Madam mentioned something about checking the blood sugar on the same
Sudeep,
morning.
please,
Actually, I have stopped checking blood sugar on the same morning because they all, like she said, they're under stress and it'll always turn out to be high. So stop doing checking blood sugar on the day of the surgery.
I still think it makes sense, because supposing they've missed out a tablet and in the waiting time, they could take the medication. So, I mean, we can't.
How about medical legally? How about medical legally? Medical legally, if you don't do on the same day, and something happens and you get sued, and then they say you didn't do your blood sugar on that day, and if it is high, you should have postponed.
We have the HbA1c also, always. All patients do the HbA1c. So if that is controlled,
So we don't have a consensus on this because it is not very sure that how much you control and all those. But then they definitely have to be under control. We have to tell them, and then they have to be controlled post-operatively also. So just on the day of surgery, for our medical legal purpose, if you lower and they don't control it later, that is not also fair. So that a lot of counseling has to go into this diabetic people who are less controlled. So we move on. Dr. Ilan, pre-op OCT. Let's make it short.
No, you did not discuss about blood thinners.
Yeah, I discussed. You did not tell anything.
Oh, I didn't tell. No, blood thinners.
Sudeep said, yeah.
No, it should. Doesn't make too much sense in stopping the medication. Yes, it's better to keep them on, especially if you're doing a phaco. But if you're going to touch the conjunctiva, do a trab or a pterygium or any similar procedure, definitely we have to stop the blood thinners 5 days in advance.
So we agree on that. And then, Ilan, do you do OCT all cases? How do you charge? And otherwise, what do you explain? Let's make it short.
From a position of saying no OCT in cataract, reached sometimes OCT in my advanced IOLs. Now we do OCT in all cases of cataract surgery. I would just like to quote a small study for this. It's one of the recent studies. Nearly 40% of the patients undergoing cataract surgery had some changes above the age of 60 years, had some changes in the macula. Of these 40%, 50% of that, that's around 20% of them, could not be diagnosed clinically despite seeing the retina. So this makes it very clear that we should do OCT in each and every case of cataract surgery whenever it is possible, if it is available. And in any case of doubtful cases, send it outside and get it done if you do not have it. That said and done, this is for the posterior segment. How do we charge? It is usually a package. We charge 3,500 rupees for a cataract workup, which includes an optical biometry, which includes a OCT, which includes a specular count, and which includes a pentacam. 3,500 for all this. Individually, if you take, it will be double of it. As regards the third thing, there are other uses of OCT also, like an anti-segment OCT will help us in diagnosing a pre-existing rent in case of a dense cataract where we are suspecting a posterior polar. Or in some of the corneal cases, it will help us place our incisions properly. So my opinion, OCT in all cases.
Thank you. Yes, that was clear. Naveen, what do you say?
I would like to do OCT in cases where I see the fundus and if I see anything wrong in the macula. And if I'm doing higher end cases like multifocal and toric, I don't do OCT in all the cases. I have a spectral domain. I don't have source OCT. So anyway, if it is grade 3 and above, we don't get a good image OCT in all the cases. So if the macula, if there is any doubt, if the diabetes is uncontrolled, then I do it, or else I don't prefer to do it now and burden the patient. I don't include the OCT in my normal cataract package, so I don't do it on my for the routine patients.
Okay, so we have done also a PG thesis on this, and the similar result what Ilan said. 25% of cases which did not show on indirect any macular changes had some kind of lesions which could be picked up with OCT alone. So basically, if you don't have, you can always tell that nothing is clear, and you can have a problem later. But if you have the facility, we charge half of our regular charges, and then do it for all the patients who get a good view through the cataract. Okay, so we move on. Timing, bilateral. People come with bilateral cataracts. Let's say advanced or not advanced, doesn't matter. But then timing of second surgery. What do you tell the patient? And how do you decide when to do? Dr. Chitra, please.
See, we would largely prefer to do our second eye of our patient a week after the primary surgery. See, basically, even if it were a remote chance of an infection, for it to manifest might take 2-3 days. So that you need to buy time instead of doing it on the same sitting for both these eyes. And again, there is some amount of inflammation in these eyes, and to feel good and comfortable, it takes a week for them to be happy. Maybe a week would become 5 days. The patient is coming from abroad or traveling. And the other important thing is, if you're doing a premium IOL, sometimes what happens, although you have made the promises of target emmetropia for all distances, the patient might have a small reading difficulty or a distance issue, wherein you could do a micro monovision correction or choose a different kind of a premium lens, which would take care of that range of vision which they have lost out. So giving this kind of a week's interval seems to be a very practical approach.
Thank you, madam. This is mostly because most patients keep asking. See, once you do, what about the other eye? They have bystanders waiting to finish off both. They would have come from outside because they don't have support, or they want to finish off all the medications together. They want to get it. Even last week also, one patient wanted to do it on the same day and asked me, why don't you do it on the same day? I'll take all the risk and all this. So, Sudeep, what do you do?
No, very rarely I'll do it on the same day, because the same risk that Dr. Chitra mentioned. So very often I will see the patient the next day post-op and the day after that. So the second post-op day, I'll go ahead with the second eye surgery. It's not just infections, it's things like IOL, the power surprises. And we know that a lot of these reactions which happen, which are unexpected, but then you know that it will react exactly the same way in the second eye. Both the eyes react exactly the same way. So that's why I prefer to do it. But then there are certain situations where you need to do under general anesthesia, certain people who are just not cooperative, who are probably have psychological problems, children, or be needing general anesthesia. So these people probably will do both at the same time.
Okay, thank you, Sudeep. So the point is, generally we don't tend to do it on the same day because of all these problems considered. But I would always tell a patient who is taking the surgery close by that the feeling which you may have, the experience may be different, because many of them come and tell. The first one was like this, the second one was like this. What was the sound which you heard that was happening with some other machine? This was a sound music show. The 3 lights were seen. All these patients will appreciate and tell you. So tell them that this is a global phenomenon, that you will feel everything, something different, but the whole thing is the same. So that, some conjunctival hemorrhage, something if you have, then again, they don't say that the other eye had no problem, this eye had redness. So these things have to be explained to them when they are taking in short period. Otherwise, then they will tend to forget if it after many months. Okay, so then we'll move on. Multifocal IOLs. Dr. Naveen, please. Multifocal IOLs for congenital cataracts. Have you done? What do you say?
No, I have done congenital cataracts, but I do not prefer multifocals in congenital cataracts. The reason being, this lens has to sit for another, say, 70 years. And there is bound to be contraction. There is capsular contraction, and there is bound to be drift in the angle of the central rings. And if that happens, there will be chances of lot of higher order aberrations. The patient will not be able to tolerate it once after 10 years. So if there is a shift in the ring, because of the capsular contraction. I would prefer a 3-piece monofocal, maybe overcorrection in one eye, but definitely not multifocal in my pediatric patients. No, that is my opinion on it.
Unilateral cataracts? Unilateral cataracts
Both.
also? Both.
Yes, both. Yes,
Okay.
both. Yes.
Ilan.
Yes, I agree with what Dr. Naveen has said. Now, I would like to slightly differ from that. Anyone above 7 years, unilateral cataract, if the patient is willing, after explaining all the problems, I might still go ahead with a multifocal lens. Anyone below 7 years, because there's a drastic change, not only in the capsular contracture, but there's going to be a drastic change in the IOL power calculation. And many times we go wrong. I wouldn't prefer to use a multifocal IOL. If you want a generalized statement, children, I would like to avoid, but above 7 years, considering that they've already seen the internet and then come to us, if they're highly motivated and ready to face the risk, I will still consider multifocal.
So just to ask Dr. Chitra and Dr. Sudeep, any difference of opinion or anything you want to add on?
I think it stands to reason that a little older child, you could do a multifocal implant after a proper counseling. Maybe not a newborn child or an infant.
Okay. So
I will not go for a multifocal. No.
Just a small question. Like we mostly see children, not children, above 18 years also, we do see people having coming up with congenital cataract. Do you prefer a multifocal in these patients?
Yes.
If it is a unilateral cataract, yes. Because the present day multifocals are, the way we evaluate the eye, the cornea and all the parameters, multifocal lenses and with the kind of biometry, it is a great choice if it is a unilateral cataract.
Yes. Thank you.
Provided it's not amblyopic.
Okay, to this I want to add something. There are two diverse studies, both of them but concur with the statement that whether you use a monofocal IOL or a multifocal IOL, the development of amblyopia, the development of fusion, both eyes fusion is the same, but both of them end with saying that contrast sensitivity is reduced in a multifocal IOL. That might impact the vision development later.
Okay, that was a question in the chat box also regarding amblyopia.
Yeah.
So we move on to the next one. Dr. Mridula, please. When you correct astigmatism and you use toric lenses, how do you start with the rule astigmatism, against the rule astigmatism, and in monofocals and multifocals? What is your minimum cutoff, and how do you proceed?
See, I do a lot of toric lenses, and basically we start screening them from the optometry. So what we do is
Mridula was paused in between.
Yeah.
So voice, yeah.
Audible?
Yeah.
Anything within above one diopter of astigmatism, we definitely consider doing a toric lenses for irrespective of whatever it is. Unless it's a very hard cataract where you can expect a that when you keep a toric IOL, there is a possibility of rotation. All other cases, I definitely do toric lenses.
So from 1 and above.
1 and above. 1 and above. And my incisions, I don't change according to the the patient. I always do 180-degree incisions. So the IOLs are calculated with my incisions remaining the same at 180-degree. And so I, according to the lens, I place the lens.
Yeah, Mridula, I missed out on the question of pre-op OCT for you. Do you do in your center?
I agree to Naveen. Actually, I do OCT not on routine cases. I do the OCT on if I see anything in the macula, if any problem, kind of a dull glow or anything like that. Most of the diabetic patients I do, considering the minimal diabetic edema, which could be a possibility of reduced vision post-operatively, and all the multifocals I do.
Okay.
OCT.
That is clear. Okay, Dr. Chitra, when multifocal torics. Astigmatism. Multifocal torics and with the rule and against the rule, please.
See, with the rule, against the rule is a very important thing before you plan your toric IOL implantation. So if it is against the rule, you could even start correcting astigmatism from a smaller part, simply because majority of the cases, it's in the posterior corneal astigmatism is against the rule. And if there is an against the rule and anterior cornea, it gets additive. So you would start planning astigmatic correction even from a 0.75 of against the rule, whereas with the rule you would not, it would become vice versa. So what I would do is, after I measure the amount of astigmatism, I would feed it on the Barrett's toric calculator, which will tell me that do I need a toric IOL for this particular astigmatic correction or would I not need it. So largely, if you want just a gross idea, definitely even from 1 diopter of astigmatism, I would definitely want to correct it. Again, if it is a multifocal IOL, I would be even more strict about, intolerant about any amount of astigmatism getting missed out, unless it's a very small magnitude, because these multifocal IOL patients are very significantly affected in the quality of vision, in contrast if the residual astigmatism is not corrected. And smaller grades of astigmatism, if I am on a laser cataract platform, I would unhesitantly do an arcuate keratotomy to even address that small amount of astigmatism, because addressing target emmetropia in every single patient of yours is today, that's the way to go.
How small in multifocals? From how much on?
Even from
0.5,
0.75.
0.75, yeah. Okay. So Sudeep, anything different?
No, I think that's it. So mine also same. I use the Barrett exclusively, and if it shows, actually my counselors would have already done it, and they'll show me that it's showing toric, should we go ahead? So it doesn't show toric, then fine. And my threshold for multifocal will be even higher, like 0.75. Yeah.
Yeah, that's what. So one message is this: Barrett is freely available on online, and so anybody with any biometer can use it. And so it's good to shift to that, because you get very close to metropia in all ranges of axial length in that case. So
can I add one small point?
Yes, please.
If it is below -1, I would like to do OCCI, opposite clear corneal incision. I can correct up to -1 with my OCCI. 2.8 millimeters incision, clear corneal, not you cannot touch the limbus. If you touch the limbus, there will be cicatrization. It will not induce the astigmatism. If it can induce -1 astigmatism, if it will induce -1 astigmatism, if you go clear cornea without touching any blood vessels, then you can control up to one cylinder on the corneal plane. This is my take on this.
What is the depth of the incision?
The normal one, this I have not paid much attention to it.
Clear corneal.
And you mark it before surgery?
Yes, mark before the surgery on the slit lamp. The 2 points, I mark 2 points, my incision point on the steeper plane and the opposite clear corneal plane. And at the end of the surgery, I take 2.8 keratome and do a OCCI and close the case.
Basically,
OCCI, what he meant was clear corneal into the cornea and coming out, like your main incision.
Yes, correct.
And to get a good effect, you need to go at least 90%. To answer Mridula's question, you have to go. We need to somehow measure the peripheral corneal thickness if you want to be very accurate, and you need to have a titrated, ideally a diamond knife, or even there are set knives available. But we have done a long-term study on this, and maybe we don't go the right depth, or many patients regress. It shows up very well initial few months, but I have found in my hands it regresses quite a lot towards many years.
You know, probably the answer is in what Naveen said. Don't go, because we'll always go limbal. Probably
it's clear corneal.
Sreeni, I would like to add something here. There has been a study for this also, the opposite clear corneal incisions. It was a multicentric study. it was decided that this is not repetitive, meaning even in the same surgeon's hands, the same result was not obtained. I was waiting for the 2.8, Naveen. Actually, I was about to ask, is it 2.2 or 2.8? Good, you said
2.2 doesn't matter. No,
yeah.
it doesn't induce any
It
astigmatism.
doesn't induce any astigmatism.
And one small thing is, it is not LRI. I'm not speaking about LRI.
No,
I'm
it's a
speaking
clear
about
corneal,
incision.
opposite
Clear
clear
corneal
corneal
into the AC. Yeah, you need
this,
to have a main port. Yeah.
The first
that is OCCI. But then
Yes.
what about the arcuate cuts, which you said you talked about?
No,
arcuate cuts.
no. That's what I think.
No arcuate cut.
No.
Oh, yeah.
Only the
Then tell me.
incision. Opposite clear corneal incision.
It apparently
OCCI,
does debulking initially, but long-term results, it is definitely not predictable at all. And later on, it appears as if you have not done anything. I did it quite religiously for a couple of years, and I just gave up on it. It is just one more opening you have created on the.
Yes, after 1 year, it usually recurs back.
Okay, but there is a controversy still existing, so we'll leave it there, and then we move on to the next one. High myopia means pathological myopia, and coming with the early PCO. If a definite PCO, Elshing's pulse, no question. So early PCO, PC wrinkling, 6-9, dropping one line. Elan, what do you do?
In a high myope, definitely I would like to defer the treatment as much as possible and make the patient earn his whatever, whether it is yak capsulotomy or something else. I prefer yak capsulotomy only much later, not for a 6-9 vision in a high myope. And I always take care to do a proper indirect ophthalmology. And in case of a doubt, take the help of a retinal surgeon, laser all the doubtful areas, and then go ahead with the yak capsulotomy. There are a few reports of irrigation aspiration to remove those Elshing pearls in high myopia. Tried a few, but usually they recur and need multiple treatment. So my treatment of choice even now is an yak capsulotomy, but as late as possible and after ruling out all the other retinal problems.
Okay, Naveen. 1 minute, madam. Naveen, and
yes,
then
madam.
we'll come.
Yes, sir. My thing is, I agree with Dr. Elan as late as possible. But one small difference is I would like to take my retina person's opinion. I would like to see the periphery, and if possible, do a 360-degree barrage and then do a yak cap. This is my take on it.
Retina persons will kill you.
I would advise that you should high myope, definitely delay it. And if you're going to do it, it's best if there is a PVD which is already there.
Yes.
Then doing makes sense.
Okay, and how often do you review? Ask them to review post YAG, because we had people going back and coming back with an RD after 1 month. So, do you ask them to review more frequently?
Yes. In fact, after 15 days, whatever YAG we do, call it between 1 week to 2 weeks, we always do an indirect ophthalmoscopy in those patients, irrespective of whether he's a myope or not.
Okay. Dr. Sudeep,
when I start asking questions, we're going to develop, but I can't help it. Sudeep, any road for going in, because definitely you're going to have trouble post YAG. Any role of going in with a small gauge vitrector and just cutting it, cutting the PC?
No, there's no role
theoretical.
for that. There's no role for that, because anyway you've punctured the PC. And the whole problem is the endophthalmic donosis, which happens after that, the vitreodonosis, which happens after that. So if you're going to do, you have to do a irrigation aspiration, which they were doing in Narayanatale. That was the standard when I went. And I got absolutely fed up, because the second time the PCO comes even faster. And then I started doing YAG with retina consultation, which I follow now also in Shankara. So I'll get my retina guy to have a proper look. And then, as Elan said, come back in 2 weeks, full dilatation, indirect by the retina person again. If necessary, they've been told earlier, he might need a laser if it's not done already.
Minu, fast forward.
Minimum power necessary to open the PC, not power which won't open the PC. So titrate it. Don't go very high power, which will really shake the vitreous up. Minimum power and not a very large opening.
So that's the difference between post-flying vitrectomy and YAG. Like YAG will shake up. So anyway, Minu, please.
Sreeni, to answer your question, minimum limited central vitrectomy will also cause contracture of the peripheral vitreous and traction on the base.
PVD, yeah.
So that is also dangerous.
Okay. I mean, just this controversy is okay. Fine.
So have your senior person do this. Use lesser energy. See, don't let your residents do this. Don't create a 5 millimeter large opening. Look at the preoperative pupil size and do it adequate to the pupil size and the center. Some myopes have this pupil decentered a little bit, and then you do very small, and you're going to have a very decentered opening, and you may have to do it again also. Okay, so we move on. So we'll first go on to Dr. Sudeep. Progressive myopia, subluxation kind of cases, which tend to progress whatever you do. And in such cases, if you see it on table, if it is clean on table and it's early, then it is okay. But you see it on table that it is shaky, and this is not just a traumatic one, it is a pseudo-exfoliation, it's an RP, it is a myope or whatever, and it's going to progress, or other progressive diseases, then what is your choice of IOL?
If I see it, sometimes I will notice it actually there's a very gross subluxation, and it's been missed in the in the OPD, and the pseudo-exfoliation, something like this, which is going to progress, then probably I'll defer the surgery. But if I notice it after I've entered the eye, then...
Defer surgery means?
Meaning if I haven't even made the incision.
But why cataract you have to do? You have to anyway do.
Then I'll send it to the retina guy. I'll get them to talk with it and plan for an SFIOL, plan for whatever later.
Oh, okay. You have the retina guy to do the SFIOL parallelly to the vitrectomy.
Yeah.
Okay.
Yeah. So do a proper vitrectomy, proper pars plana, vitrectomy, 3-port, this one, remove everything, do a laser, everything, and do it. Much safer than me doing it, me doing an SFIOL. So with increasing age, like Ellen will understand. So kirkiri bedappa. I don't want to get into all that.
Don't tell code Kannada code words. You're telling Kannada code words in between. What does it mean?
Don't want any headache. Don't want any headache. So otherwise, if I see it after it's opened, then depends. I mean, you know that if it's a progressive sort of a problem, then your CTRs and all that are really not going to help. So if possible, if I think I can do a regular clean, quick enough CT, like a CTR with fixation, at least 2 quadrant fixation, not a SFIOL, but with a CTS, then I would probably go ahead with that. But otherwise, I'd probably, if it's a very bad subluxation, I would leave it aphakic and again plan for proper vitrectomy SFIOL by my retina colleague. But I have the luxury of having a retina person. That may not be possible in a single practice.
Do is, if it is a case which is a pseudo-exfoliation on RP, but the amount of subluxation is less, very much less on the table, I would place a CTR and I would actually leave the IOL haptics in the bag and do an optic capture. Haptics in the sulcus and do optic capture in that early stage. But if the subluxation is a little more, then I would place a CTR and plan a single CTS or 2 CTS. But when it comes to, if I am going to be doing the surgery, if it is significant subluxation, I would like to complete it by retrofixating, doing iris clip lens. But only in a situation where due to some reason, I'm going to forward it on to for an SFIOL, then I would ask my retina surgeons to take care of it.
So, Mridula on this?
Yes, my preference will be the same, like CTR if it's possible. If it's not possible, I straight away take out the lens and put an iris claw lens. So because I've been doing a lot of iris claw lenses, I'm quite comfortable in that. And in fact, getting not bad results also. So, and if it goes beyond that, then Dr. Rekha comes to help me.
Yeah, you should always combine it with a PI also.
Yes, iris tolerance. Yes,
Dr. Rekha means retina person.
Yes, retina person.
Okay. So basically,
one point. Whenever I see this Zorilla dialysis patient, my eyes lights up because doing routine surgery every day is a boring thing.
Mhm.
This is a challenge for me. First
Yes.
thing I would like to do is save the bag as far as possible. Save the bag. Put two CT Ahmad segments to or 180 degrees apart, and put the single piece IOL in the bag. This is my first goal. If that is not possible, my second choice is put a iris claw lens. If I have damaged the iris, the third choice is SFIOL through Hoffman pouches. These are the three options I keep before going into my zonal dialysis surgery. But if I do see a ZD in my OPD, my eyes really opens up. I love doing the surgeries.
See, Sudeep, there are youngsters who are becoming happy seeing it. Seeing this one. That means we all are growing older. Okay. So point is, what I would add on is that I will show these patients on the video slit lamp that this is your case. And this is not going to stop with this surgery. And we are nowadays seeing many people coming after 5 years, 7 years, 10 years, coming with bad subluxated bags in the vitreous, in the AVF and all. So keep it in the back of their mind that this kind of things may happen. That will sometimes scare people, or it's not like threatening patients, but then bystanders at least should have been told that this kind of possibility will exist. And a CTR inside the bag, although it doesn't prevent anything, it helps you in suturing this thing back very atraumatically. That we have done in many cases with Gore-Tex suture. And removing it as placing it in the sulcus is a very good deal. Actually, many times it delays this fibrosis and the contracture and gradual progression of sonal dialysis. But then, which techniques works best with you would be best. If you're good with scleral fixation, do scleral fixation. If you're good with glued IOL, do it yourself. Iris claw, also fine. AC IOL, well done, also fine. There are meta-analysis studies which show that AC IOLs are not out. Well done, well calculated, well prepared eye with vitrectomy and sizing properly. Thank you on that. Then we move on to a corneal problem. Not too much to discuss, but then still, an endothelial dystrophy you see on the borderline, not too much of corneal edema, not a obviously decompensated one. Desec with phaco or any kind of a corneal procedure with phaco, or phaco first and then later on decide on this one. Ellen, what do you do?
Normally, I would like to do phaco first and go ahead with the other procedures. But then I would like to add something here. Any clinically seen subepithelial bullae, this means that the endothelium is not working, can better plan a combined surgery. Any specular count, say 1100, below 1000, definitely this is not going to help us plan a combined surgery, that is phaco with desec. And if we don't have a specular plus minus subepithelial bullae, then what I would advise is look at the corneal thickness. The thickness around 640, 650, this is not going to survive. In most cases, there are exceptions. Then I would like to combine the surgeries. Now, why only phaco? Number one, we have become as less traumatic as possible. There are dispersive chondroitin-based viscoelastics which are available, which help in endothelial protection. And third, and most importantly, significant developments in endothelial reproliferation is happening in the cornea. In fact, in many of the central guttae only cases, central guttae with very low endothelial count also, it has been proven that phaco with desmetorexis with this natrosudal eye drops has definitely helped. So I would do only a phaco if it is clinically normal, clinically, or all these 3 points, what I said.
Naveen?
Yes, to add, I completely agree with Dr. Elan. To add to this, I would prefer Alcon nozzles, wherein the energy and the heat which is generated will not reach the endothelium. And second thing is, I would not use sodium hyaluronate in these cases. If I have used sodium hyaluronate, I would like to remove it, replace it with chondroitin sulfate, and then continue with the surgery, because heat always transmits better in sodium hyaluronate than the HPMC or chondroitin sulfate. I would prefer chondroitin sulfate to coat the endothelium and then go ahead with my surgery with only ossils, no conventional phaco. with as much little phaco as possible. This is my take on it.
Okay, that is very clear. We'll continue with this on the OBD preferences in phaco.
Yeah.
Am I audible?
Yes, yes.
Yeah. And Dr. Chitra,
Yeah.
what is your regular HPMC is what we regularly use. Everybody uses just
yes.
Other OBDs. Yes.
Yeah, I would prefer to use HPMC for all my routine cases unless it's an intermittent cataract, wherein I would like to use, I would prefer to use a viscodispersive and then of course the small rexes and all the other issues which come with it. When you're talking only about OBD, if it is endothelial cell count is less, then I would not just use a high molecular weight thing. I would prefer to we use something like an viscoat or an oro coat and inject it to coat the endothelium, and then I would inject methyl cellulose to do the phacoemulsification, because just leaving viscoat in the eye alone, you could rarely get a wound burn. And then again, if there is a PC rent which has occurred, then I would like to, and the vitreous is not coming forward, at that point I would use visco to plug that area of vitreous from coming forward and do a very careful completion of the surgery.
Okay, so the
small eye, again, I would use look at using cohesive viscoelastic to create space in the eye for me to do
yeah.
I think it's the same. I would use chondroitin sulfate sodium hyaluronate combination when the endothelium is compromised. But otherwise, I would probably go ahead with HPMC.
So, Mridula, which is your choice of combination of this? You use viscoat or the Indian companies also? Indian companies also you use, or just viscoat?
Yes.
No financial interest on this.
No, I use everything. I use all these HPMC, Indian companies, viscoat, Orocoat. Like Madam was telling, I mostly use, depending on the finance of the patient also. If they cannot afford that viscoat, then go in for a lower one. But I explain everything, and depending on the situation, I use it accordingly.
Yeah, so when required, I think we should be willing to use chondroitin sulfate combinations, which in India are cheaply also available. And when required, we should have a mindset to add it on while doing phaco, so that you have clear, good corneas. And also while placing IOLs, I nowadays use, in all cases, I use Orogel, no financial interest in that. It is not that very costly. It is the cohesive one, so it comes out completely, and there is no problem in leaving visco at the end of the surgery in the angles, and you have a spike of IOP immediate post-op.
Even phakic IOLs, yes, I would prefer to use that.
Yeah, so encountering next is a very fancy question. Other eye multifocal, and you have promised a multifocal in the other eye, you have to, and then you get a PC. What do you do on that? So the question is to Elan.
PC rent in any case is not the end of the surgery. If we can recognize this PC rent, particularly the central PC rents, if we can recognize, we can salvage, still recognize it early and do a proper management, we can still salvage and go ahead with a multifocal IOL in the eye, in the back. If it is a peripheral PC rent also, still it is salvageable if we can put it in a slightly different axis, but then we should also remember that if it is a large PC rent, there's a high chance of this IOL getting decentered, in which case, even with single piece IOLs, I would like to reverse optic capture the optic, if it is possible to place the lens. In case of worst cases, when it is not salvageable, I wouldn't hesitate to put a monofocal IOL. So my monofocal IOL in the sulcus and optic, the 3-piece monofocal IOL in the sulcus and optic capture it. So my preference is, as much as possible, try to do the minimum possible and retain, make a small, the PC rent to be small and put in the bag multifocal IOL. In case that is not possible, or in case of any doubtful situations, try to reverse capture it. If that is also not possible, do not hesitate to go ahead with a monofocal eye oil. So it depends on
What is the power?
Expand on that, reverse
reverse
capturing means you place it in the bag and then tap the optic up above the
yes above
rexus
the
margin. That's
yes.
what you mean.
Yes, actually, ideally speaking, we should go for a 0.5 lesser. But in case of private practitioners like us, multifocal, we don't have a full inventory. So I don't hesitate in putting the same multifocal eye oil and reverse capturing. It has happened a couple of times for me. I have captured it and they're doing very well. They have around 0.5, 0.75, but usually they don't mind rather than leaving them completely with a monofocal.
No, Ellen, actually, one question. If you're going to put in a monofocal lens,
yes, ma'am.
Do you adjust the power?
Yes, ma'am. If it
so
is
that,
put in
so
the
that make it more myopic, because the other eye is multifocal.
Yes. That's why I told the previous one. Definitely make it around 0.75 to 1 myopic, in which case we need not same power we can take, put it in the sulcus and 0.75 over lens, put it in the sulcus and capture it. In case of a monofocal.
I would want to add, if it is a small PCR, then we should convert it into a PCC, because even the process of putting in an IOL in the bag, you can enlarge it. Otherwise, if we do keep a battery of three-piece multifocal IOLs, which we would use and do optic capture by placing it in a sulcus after doing a vitrectomy. Reverse optic capture, you need to have a very small rexus if you're going to bring a single piece up. And because there is no angulation, it is probably not the best way to go unless you are in such a major compromise where you can't help it. I don't think that should be announced as one more option to do in this larger audience.
Naveen, what do you do with the counseling part? Counseling initially.
Yes. Counseling part, if it is a PPC, then I would like to tell them that there is all possibility for me for not putting the multifocal, and I keep a backup three-piece, and I don't hesitate to put three-piece if there is a rent and I can't salvage the rent, which is if it is a round and central, and as Madam told, if we can convert it to a PPC, I still prefer to put in a multifocal lens in the bag with optic capture. I would like to slightly differ from Madam. I always do optic capture because it says the center. If we do the optic capture, especially in multifocal, we want the rings to be center. That is our goal. If the lens decenters, there will be a lot of higher order aberrations. Patient will never be satisfied.
If you want to optic capture, if the bag you're going to place the lens, optic capture comes in when you're placing it in some other position like a sulcus, then you would do an optic capture, or when as you're going to do a reverse optic capture. If you have the proper posterior capsular rexus, you can leave it in the bag. You have anyway got a nice round rexus.
Ma'am, no, I made it very clear. If it is a central thing, of course, I didn't explain the capsular rexus, posterior capsular rexus. If it is central, we can leave it in the bag without anything. If it is a slightly peripheral one, where is a threat of subluxation, even at the slightest doubt, I do a reverse optic capture.
Yeah, the point is well taken. The only thing is that when you tell, there has to be somehow, if there is something happen like this, and if you don't keep a promised lens, then this will psychologically impact a patient a lot. You can't say who will react which way. So some warning should be given, so that there is a possibility that sometimes it may be a monofocal. It's a very, very rare possibility. That should be at the back of their mind also. But many cases, it is easy to place, but then post-op, we have to deal with them a little differently. If you have done a vitrectomy, look for a CME, look for the peripheral retina post-operatively, and then manage well. So we have 10 minutes. That's what Sreeni has told us. We'll go quickly through the 2-3 other presbyopic lens exchange. Nowadays in the West, it's getting a fashion. 45 plus, you have a dysfunctional lens. Why don't you come in and get it fixed? So what do you say? Will you fix it, Sudeep?
Yeah, provide the posterior segment is absolutely all right. Patient is highly motivated. I won't, the suggestion shouldn't come from me. If the patient wants to get rid of his presbyopia, whatever, then fine. Or whatever aberrations he's got, and he's really bothered by it, HOAs, then yes, but otherwise no. So posterior
Yes.
segment should be absolutely fine. He shouldn't be a high myope. He shouldn't have potential. Shouldn't be like a uncontrolled or a high diabetic. He shouldn't be, let's say, a glaucoma patient. All these things have to be ruled out completely before I deal with this.
Yes, Chitra madam.
And also in continuation with what Dr. Sudeep said, ideal would be plano, presbyopes or hyperopes. Even a low myope with an early cataract is happy with his near vision. So he is not going to be very keen for if it is, we are talking of clear lens exchange. If you are talking of, the other extra points is when we are doing a refractive lens exchange for our patients, we have to be very meticulous in our pre-op evaluation, right from dry eye status to ocular, OC, macula, and everything. Biometry should be absolutely top class. Repeatability between the different readings, everything should be done. There should be nothing which is left aside. And then again, when you do one eye, it's better to give a wait of a week to see how the other eye is doing. That 99% of the situation will be all right, but rarely you might want to change do a mix and match might be needed. And as far as the higher order aberrations, I'm not talking in continuity, but one important thing which again we have now is, like earlier on, we used to say that an angle alpha being more, then you differ from going in for a premium multifocal lens and all that. But nowadays, the advanced, like in pan optics and synergy and other lenses, the central optic zone has become larger. So you can even have an angle alpha of 0.8 and still suggest a multifocal IOL for these patients. So today, with the present biometry which we have and all the pre-op investigations which all of us on the panel are very rigorously doing, I think more and more, and of course a femtocataract platform which we also have. So more and more of we have confidence to do a presbyopia lens exchange for a patient with good counsel.
So patient motivated, as Sudeep said, and as Madam said, all hitting the target.
Yes.
Target is very, very important. So that is why the workup and all those things, because these people are very sensitive people. So they would want best results. So for that, the technique, the lens which you choose with your experience, which works well for you, and the preoperative evaluations which have to be very strict. So post-operatively, we'll go on to the use of steroids. See, we continuously give the same kind of steroids, or for a longer period, even if you see 1 week, 2 weeks later, there's no reaction, totally quiet patient, but we follow the same kind of routine for most of the patients. So do you do the same way, Dr. Naveen? Or do you change to a weaker steroid, or what do you do?
Yes, sir. If it is a steroid responder, I will stop my steroid within 3 or 4 days and switch over to NSAIDs. If it is steroid responder, or else routinely, if 90% of my patients I would like to separate my antibiotic with the steroid. I prefer prednisolone rather than dexamethasone, and I give my antibiotic separately so that I can taper it differently. This is my take on it, sir.
So everybody, how many weeks do you give?
I give it for 3 weeks.
Just 3 weeks of steroids and stop?
Yes. Tapering dose.
Oh,
tapering dose. Okay.
We give it over 6 weeks on a day.
And Elan?
4 weeks, 4, 3, 2, 1 tapering dose.
Okay. 4, 3, 2, 1. And Chitra madam, 6 weeks. Sudeep?
Yeah, usually 4 weeks. But then some of them come back, if I know that they come back with rebound inflammation the next time, then I'll probably use it for 6 weeks. But then I have been trying to see whether the Ilevro and all will really work without steroids, but I haven't really got around to doing it. I've heard a lot of people using only that and not steroids, but I haven't really got around to doing it.
There are people who use only lotipred also, lotiprednol also. Just
yes.
that.
Minu, if I can just make it very...
use lotipred only. We do not use stronger steroids.
You give routinely lotipred. Okay.
Only lotipred with Nevanac combination, BG.
And
Lotipride is supposed to be a surface steroid.
And
but actually it is supposed to be, but then it actually penetrates. There are studies that show that lotipride has AC concentration. Mridula, what is your protocol?
No, yeah, my protocol is again 6 weeks steroids, but like what Dr. Naveen was telling, I separate the antibiotic. So I give it only for the first 15 days. After that, it's not given. And Nevenac, I do include. But I just wanted to ask, just put in a word. I saw one of the patient who has been operated in Calcutta, and for him, he was not using any of the drops. And the doctor had told that they have put the steroid and the antibiotic inside the eye, and they've not given any prescription, just the artificial tears. Can somebody suggest on that? What was
yes, Ellen is showing hands.
Yeah, ma'am, I did this also. It was the long steroid. What do we use that? Triamcinolone acetonide. Triamcinolone acetonide. It is not a posterior subtenance. It is slightly.
It's inside the zonules.
No, ma'am. No, I have not tried it inside zonules. No, the prescribed literature is a combination of triamcinolone acetonide with an antibiotic behind the zonules. That is what is prescribed.
Yes.
But what Dr. J.K. Reddy sir from Coimbatore, Shankara Coimbatore, I started seeing his cases. What he was doing was in the infero nasal quadrant, it's anterior subtenance. We used to give 0.2 ml of 40 milligram per ml of triamcinolone acetonide. This, but along with this, I used to give 1 week of antibiotic. Always I give antibiotic and steroids. I used to do it separately. 1 week of antibiotic and even no need of Nevenac. We used to leave it off. I have around 40 cases where there was no problem. But because there's no published literature, I was hesitating to take it further.
What about the pressures?
IOPs you have been checking?
Yes.
IOP.
Yes. These
and you will get into trouble. You don't know who is going to be a steroid.
Yeah, that is the problem.
You have a transfer there, you had it.
No, 1 minute. Why did I
Because
stop
whenever you use a triamcinolone for if there is a rent, it will shoot by the invariably it will shoot up to 40.
No. See, something behind triamcinolone, you can take it out. If it is in the vitreous, okay, you can do a vitrectomy somewhere there. Minu, we are running short of time.
Yeah, running short of time. This is
we'll stop with this.
We'll stop with this, but then whatever we are comfortable. See, 3 weeks is news to me. 3 weeks also is comfortable. So that is what we should realize, that customary 6 weeks to 8 weeks and all, it is not required for all patients. But there are people whom we have to customize, especially if you have an intraoperative complication or a preoperatively complicated patient, we'll have to customize. But then on a routine basis, I think, see, madam gives only lotipride, nothing happens. So otherwise she would have stopped. Yeah, if patients are coming back with reaction, she would have stopped. So that is what we need to take from everybody's experience, that we need to customize for different kind of patients. And so with this, we will come to the end of this session. We have covered a lot of points and all were very practically useful from veteran surgeons, and hope this helps most of the practitioners. And thank you, Sreeni, for this opportunity.
I think kudos to Dr. Minu for putting in such wonderful set of questions and how he distributed so that all were covered. I'm feeling so bad that 3 important questions are left behind, but 3 cheers.
We'll call you for another one.
Cheers to you.
Cheers to KSOS.
Thank you so much. Thank you so much for KSOS.
Thank you.
Thank you so much. Dr. Sreeni, Dr. Minu, thank you.
Yeah.
Thanks a lot.
Thank you. As usual, a super session from Minu. Like, you have a session with Minu, don't miss it.
Definitely. Agree. Dr. Sreeni, agree. You're telling me now I experienced it.
Okay. Thanks, everyone. Now we'll move on to the next session, which will be on pediatric ophthalmology, controversies, and Dr. Rohit is there to chair, and Dr. Akshay will convene the session. And Dr. Akshay is a pediatric ophthalmologist and neuro-ophthalmologist trained at LV Prasad Eye Institute. He's a proficient squint and pediatric cataract surgeon and an avid researcher, teacher, and educator. Currently, he's working at Ahilya Hospital, Palakkad, Kerala, as a consultant in pediatric ophthalmology and neuro-ophthalmology. Dr. Akshay, I request you to introduce the speakers, Rohit and everyone, and carry on with the session.
Thank you, sir. Thanks for the introduction and thank you for this opportunity. I hope I'm audible and my slides are visible.
Yes, Akshay, please go ahead.
Yeah, thank you, sir. Thank you. So welcome everyone to the topic on controversies in pediatric ophthalmology. I'm sure we'll have a very rich and a lot of learning in this session. It's my proud privilege to introduce our chairperson for today, Professor Dr. Rohit Saxena. He is known to everybody in India and around the world as a very proficient pediatric ophthalmologist, dermatologist, and neuro-ophthalmologist. I can go on and on about him, but I think to say a few points, he's a very good clinician and surgeon, an excellent teacher. He's a very avid researcher. You can see he has more than 300 publications. He's also helped residents with their theses. He's been to a lot of conferences, both nationally and internationally, as an invited speaker. And he is the principal investigator of a number of very, very important research topics. So I welcome you, Dr. Saxena, as the chairperson for this session. We have some exciting talks lined up. Dr. Murali Kaushik from Shankara Eye Hospital, Bangalore will be talking on managing childhood myopia. We then have Dr. Neena from Giridhar Eye Institute will be talking on acute comitant esotropia. Dr. Sandra Ganesh from Arvind Eye Hospital, Coimbatore will be talking on intermittent divergent strabismus. And Dr. Jaspreet from Advanced Eye Care Center in PGI Chandigarh will be talking on managing congenital cataract. We also have a lot of eminent luminaries as panelists. We have Dr. Mohan from Contrast Eye Hospital, Calicut, Dr. Elizabeth Joseph from Little Flower Hospital, Angamali. We have Dr. Subita Agarkar from Shankar Nethalaya, Chennai, Dr. Shubhangi Bhave from Drishti Eye Clinic and Skin Center, Nagpur, Dr. Jitendra Jithani from Baroda Children Eye Care and Skin Clinic, and Dr. Kavita from Shankara Eye Hospital, Shimoga. We are really looking forward to a very rich discussion with the panelists, and I'm sure the listeners and all of us will have a lot to learn from this session. Thank you very much, and I now hand over this session to Professor Dr. Saxena.
Thank you, Akshay. A change from the previous session, we're going to have the topics being covered a little because all are very, very interesting for I think general ophthalmologists also, considering all of these have become rather important for us in particularly COVID times. So it is absolutely wonderful that the KSOS and Sreeni, of course, has given us the opportunity to discuss this in this wonderful forum. And I'll ask Dr. Murali Kaushik to first give his presentation on managing childhood myopia, and then we'll take on some of the controversies and issues that have arisen over the past few years as this topic has become prominent. Dr. Murali.
Sure, sir. I'll just share my screen. So congratulate KSOS for looking at a session on pediatric ophthalmology just after a cataract session. I think it's probably a first for us pediatric ophthalmologists to land up at a prime time slot, so to speak. Again, thanks to Dr. Rohit for inviting me to be a part of this panel here today. So my talk is going to be around childhood myopia. After about 1 hour, 15 minutes of cataract, where we spoke of multifocals and femtocataract, why should general ophthalmologists even bother about myopia? So myopia today has been defined and agreed that it is a condition where the refractive error of the eye has a spherical equivalent of less than minus 0.5 diopter when accommodation is relaxed. We know it is a significant public health issue with significant vision loss, and there is a risk of other severe ocular conditions happening. From a percentage standpoint, various studies showed between say 7 to 12% of the population having it. Again, what's the big deal? 80-90% of children are probably normal. But then we are India. Our children population is equal to the maps of all those countries that you see there. You add up Russia, France, Germany, the entire United Kingdom and France, and Italy, that probably is our children's population. So the minute I tell you 10% of these countries, is it important? I'm sure everybody listening in is going to say that, yes, of course it is. The first challenge that we face when parents land up at our clinic and we tell them that their child has a refractive error and requires correction is the typical Bangalore thing of Salpa adjust madi, which means can you adjust a little bit? Then the bargaining starts. Can you actually reduce it a little bit? Does my child actually require full correction? And we do see a number of our colleagues also end up undercorrecting children, saying that the child will get used to it beyond a period of time. Again, there are enough literature and evidence to support that unless there is any clear evidence, it just does not make sense, as there are much better alternatives today available to slow down myopia progression. Undercorrection definitely affects the functional vision of the child. It results in educational delays. Of course, there also is a risk of bullying and ostracism that is inherent to spectacle use, and more so when the child is not able to function completely with the glasses on. Again, Dr. Rohit and the entire national consensus group has come up with guidelines in terms of what should be prescribed. So we just need to adhere to that and be very clear that we are prescribing the complete power. But myopia management is just not about prescribing the correct glasses. Myopia management is trying to saying that how can we actually reduce the progression of myopia, and a large number of the optical devices. So just giving a single vision glass is not myopia management. So we need to see if glasses or contact lenses can be tweaked. The largest kind of logic that has been used is the concept of peripheral defocus, where it is believed that the eye being not exactly a sphere, the periphery has a hyperopic defocus. And when you correct the myopes, this kind of defocus creates the eye to keep on elongating. The animal studies have shown that the presumed intraocular feedback mechanism is somewhere in the peripheral or the central retina. This has now been incorporated both in what are called as defocused multi-segment spectacles, where they have these little eyelets that are shown here that have little bits which have a little bit of a hyperopic ad given there. And also in terms of the orthokeratology lenses, where you're trying to just press on the cornea and make the central part clear and the periphery remains defocused. Do they really work? Honestly, I don't know. I don't use it very much. There have been various theories about how much accommodation is affected and whether this peripheral defocus really is effective, because all of us as e-metrope should have also landed up with some refractive error if this were a concern then. What has come to stay is largely atropine. The first large trial was published in 2006, where they showed that topical atropine was well tolerated and effective in slowing the progression of low to moderate myopia, as well as in ocular axial elongation. Previously also 1% was studied, but they didn't look at the biometric parameters. The subsequent studies looked at different concentrations, looked at side effects, looked at rebound, and they proved that 0.01% had minimal side effects compared to the higher doses of atropine, and they were comparable in terms of efficacy of myopia progression. But what the ATOM2 study did not do is it did not have a placebo group to kind of compare and see what happened. So the more recent study is what is called as the LAMP study, that is a low concentration of atropine for myopia progression, where they looked at various concentrations. And in this current study, they've shown that 0.05% was actually most effective in controlling progression over a period of 1 year. And again, in older age groups where it was instituted later, they again found that 0.05% was most effective. In India, commercially DCGI approved dosage available is 0.01%. And we do come across a bunch of children where it does not work. So long back before the commercial application was available, we used to remake, reconstitute and give. We also, because of this particular talk, look back at our data of the last 5 years, where we were able to fish out data of almost about 600 children who were followed up for longer than a year's time. Majority of our children, again, are females. And again, when you look at from enrollment to 12 months of follow-up, when you look at the cylinder or at the axial length, there isn't really too much of a change happening. We do see the axial length change in some of these children, but the refractive error per se doesn't seem to be changing. What is the mechanism? We are still not very clear. If you have to reconstitute, again, this was something that we published many years back. A few years back, actually, finally got published, where we showed that even reconstituting atropine and giving it as 0.01% is very safe. We followed up these children for a very long time and it was effective. So if you have to mix a 0.05 atropine, go ahead and do it. It is not unsafe to do that. Along with that, the second thing that we found work is sunlight. Again, various theories from light intensity to the dopamine release to less near work when children are outdoors. There have again been structured studies practically from across the world that showed that being outdoors was associated with a definite reduction in terms of the myopia progression. And for every hour that the child spent, literally their myopia decreased. So the PT periods probably played a big role. So I would encourage KSOS to use their advocacy platform to encourage the school curriculum to probably include a lot more of outdoor play. Again, we looked at our own data where we looked at children with parental myopia as an additive factor to atropine treatment. And we found that children who were more than 2 hours outdoors, these children had much lesser myopia control. So the least every general ophthalmologist could do is encourage children to spend as much time outdoors. Through lockdown, again, something interesting that we've been picking up, we know that serum vitamin D has been shown to have an impact on myopia. We started looking at children with parental myopia, just looked at their vitamin D levels, and we found almost 76% of them to be deficient. Again, the backdrop is a lot of children in India are by and large vitamin D deficient. So is this an aberration? We don't know. But children who were hypovitaminosis D showed much faster progression. And once we kind of corrected it, we did see a slight reduction in the vitamin D levels. Again, as general ophthalmologists seeing children, there is no harm in getting their vitamin D levels tested. And if it is low, get our pediatrician colleagues to actually correct it. All these various modalities have various efficacies. It ranges from say 20% to 80%. But some improvement is better than no improvement. So here I've hypothesized an 8-year-old child with a -1 diopter who is progressing almost a diopter a year. And imagine if we were to institute, then at the age of 16, we would have prevented him from being at a -6 myopia at that stage in time. So whatever it is, I think it is important for every one of us to be aware of literature that is available and very quickly see what we could intervene to kind of control the myopia.
Thank you, Dr. Murali. Excellent presentation and essentially covered all the major issues. He's actually put to rest the first major controversy that we frequently come across is undercorrection of glasses, particularly if a child has been noticed to have myopia first time. In young children, many ophthalmologists would say that it's a too large a number for a child of this age, and let's give him a graded increase in his myopic correction. And as Dr. Murali has said, that firstly, there is no advantage whatsoever of undercorrecting as far as progression is concerned. And obviously the image clarity is so poor that, or at least poorer than normal. So obviously, if he has associated ametropic amblyopia, it's going to take that much longer for it to develop. Any suggestions or any comments as far as undercorrection is concerned? Dr. Shubhangi, please.
If myopia is associated with esotropia or small esotropia or esophoria, then would the panel like to undercorrect myopia or add prisms? That was one thing. So, Dr. Kaushik or Dr. Neena, would you want to take that? If there is a small, we should differentiate this from a child who's come for the first time. So he has a small ESO with high myopia. Probably we just give him, I would suggest that we give him glasses, appropriate correction first time, and then see whether this small esotropia or esophoria can actually get corrected with the divergence, fusional divergence, and then on subsequent follow-up take a decision. I would say if it's very small and it's below what you would consider safe for surgery, you would think of prisms. But any thoughts or anything, Dr. Neena, first?
Yeah, thank you, Dr. Rohit. So as you said correctly, the child is coming for the first time, and I'm seeing that the child has a significant esotropia and a high myopic refraction. I would do an atropine refraction actually. And I would confirm that I'm only going to give adequate myopic correction. And as you have said correctly,
cyclopletic refraction is done, and still we do find cases of myopia with a small esotropia. So that time,
yes, madam, that's what I'm coming to. That's what I'm coming to. So you've done a cycloplegic with either CTC or hometropine. And I would still do an atropine refraction to find out whether there is a very, whether we're going to overcorrect this myopia. So I wouldn't want to overcorrect this myopia, but I wouldn't want to undercorrect also. So if it's a small esotropia, I usually see that in ROP children. So they usually do very well with glasses. That as Dr. Rohit said, they may be able to control it. But if they still have a significant esotropia over and above the glasses, the next thing I would see is whether it is same for distance and for near. If they're okay for distance, and if it's just for near, it could be a high AC by ratio. I then give them bifocals. So that's one thing I do. I don't usually give them prisms, but if it's a significant esotropia, both for distance and near, over the glasses, then you have to think about surgery. So, but that's a graded approach.
So just raise your hands. Anybody has any comments so that we can go around instead of directing questions. Yes, Dr. Leela. Dr. Leela and then Dr. Kavita.
Yeah. Actually, we are addressing myopia progression in these cases. When a child, especially the age is important and the myopia is not very high and esotropia is a manifest esotropia, definitely we have to address the esotropia. And if it is a small myopia, we are not very much concerned about the progression. Then for the first time when I see the patient, of course, we have to follow up the patient. So in a child of 3 years with an esotropia, which is small, and of course, AC by A ratio, if it is there, definitely we will give a correction. And I would wait before giving glasses.
Okay. Dr. Kavita?
Yeah, I think since all the points have been covered, probably we could measure the visual acuity. We could balance it with the visual acuity as well before really going for under correction. I would go for a full correction and then watch out. So visual acuity is another thing which can look at.
So this brings to one very important question. You have a child that has come. He's about 4 or 5 year old child. He comes for the first time. Parents have noticed that he sees objects very close or goes to close to the TV. Your refraction shows that he is a moderate to high myope. You prescribe him glasses. He's much better. Now, in this event, would you start any management or intervention for myopia progression, or you would wait for evidence of progression? So that's a question that I think plagues everybody who comes across a child first time diagnosed as high myope.
Can I just clarify myself? A school-going child definitely needs glasses. There is no question. He
Right.
has to be corrected with myopic correction, and he has to be followed up. I am talking about a very young child, 3-year-old.
Okay, sure. Yeah. So thoughts on such a child, Dr. Murali? Would you start anti-myopia treatment for such a child? You have a 4 or 5 year old child presenting first time in your OPD with a moderate or high myopia.
So like I said, so currently what we start is we start encouraging the child to spend at least 90 minutes to 2 hours outdoors in sunlight. So what we tell them is, if there's a calendar at home, typically most of our houses, we used to write how much of milk was used every day on a calendar. So the same analogy I use and tell them, saying that every day you got to, on a calendar, write how many minutes you spend, and next time you come back and show me that. The second thing that we've started doing, like I mentioned, was we've started asking them to get their vitamin D levels tested. And if that is subnormal, we get that corrected. And we tell the parents, saying that, look, we're going to try this. If still there is a progression, then we will probably need to start looking at some kind of a medication. And as a routine, we've now started getting the axial length recorded. So we get the biometry done. So at least I'm able to show the parent, saying that, look, the eyeball length is actually increasing and we need to see how we can slow that down. So you have to set context and get them ready to start using a medicine.
I think, yeah, Dr. Jaspreet.
Yeah, so that's a very important, interesting question, and obviously still debatable. I mean, whether to start atropine in such a condition. So recently I had this patient, a child of 5-year-old who is -7, axial myopia, got a biometry done. Parents have undergone LASIK for -4 or -5. Now in this situation, there's a positive family history. Starting atropine at when the patient presents, or waiting for progression. That is the question now.
So
Session 3 is looking into the pre-myopia control, isn't it? So I think there is a very strong family history, and there is that, you know, by an algorithm that, you know, the child is likely to be myopic. There is no harm in initiating atropine therapy. That's what it's still out to come, I think. So you have to see case to case, I guess.
I mean, the only way I would want to differ with this immediate treatment thought is that, one, he may have childhood myopia or congenital myopia, which may not significantly progress. So we should have evidence of progression. But yes, if there are major risk factors and you are worried, the other problem of starting therapy is that you do not know how effective your therapy is. The important thing now, up till now, we had only 0.01% atropine really to treat. But as Dr. Murali has shown, there are huge options coming up on the market, and many of them can be used in combination. So you could, like we are starting 0.05 hospital-based dispensing. You have the DIMS that have come up. Of course, in any treatment, you're going to add outdoor activity. So I would say that at least follow up the child at 6 months and see for progression. If he is progressing, I don't think you would lose too much by waiting for 6 months and documenting progression. So that you can actually assess the intervention. You're not going to start 2 or 3 things at the same time. So you're going to start outdoor activity and maybe atropine. And then at 1 year follow-up, see how the progression is, whether you want to up the intervention, whether you want to add something. So that would be, I think, evidence of progression and subsequently evidence of being able to intervene, your intervention being effective.
But these could be fast progressive. So waiting for 1 year.
You can call them early. If you have evidence of past progression, no doubt. I mean, if you have an evidence previous refractive error assessment which has shown progression over 1 year or more, no doubt. I mean, then you have evidence of progression. You are justified to go ahead and start treatment. Dr. Jitendra, any thoughts on that?
Yeah, actually multiple. I do agree with you, Rohit, that we should wait for progression, because at the end of the day, we are going to stop the progression, not the myopia. So we should wait. But as Dr. Neena said, it is more of case to case. You have to assess the patient individually, as we do in strabismus, as we do in all the patients. I mean, but as a blanket rule, yes, we should wait for progression. Just I wanted to add a point that we should actually check for esotropia after giving atropine. So that is also a very relevant thing when we prescribe and those esotropes who are small myopes and we have given glasses, and we are starting them on atropine, we can look for esotropia post starting the atropine eye drops. And if it is a fast progressor, maybe when we are checking them for progression, we can call them after 3 months. I mean, if we are so, we want to start something, we can call them at a smaller interval.
Rohit, I think we have
I know. I'll just put in one or two queries I just wanted. Any experience with DIMS in the panel?
We have just starting. That's all.
Okay, so I know they've been recently introduced. They are an option. Wanted to bring before everybody their option. All of us are actually starting, and we barely have a couple of patients more than 2 or 3 months. So it's difficult to say how effective they are, as Murali has talked about. But I think the panel will agree that outdoor activity is reduction in near, and thankfully now the schools and all have opened, is definitely shown to be effective and must be our first intervention in all conditions. So I think
that accommodation lab, if it is there, then even if there are some studies saying that it is a marker for progression. So in those cases, whether we should wait till there is progression or whether we should...
So we should manage. So it is, although nobody is very clear whether the accommodative lag is an etiology or a consequence of the myopia. But yes, if that definitely is there, then one would probably treat it and not myopia at the start. Probably if there is difficulty, of course, you need to check for accommodative lag as well as esophoria. So maybe you may need to follow that up separately and intervene, those are poor candidates for atropine, as Jitendra has brought out. They will be very poor candidates for atropine. They may worsen the accommodative lag. So I think we'll go on to the next. There are so many. The next one is probably even more in these COVID times, a matter of discussion. Dr. Neena will be talking on acute comitant esotropia.
Thank you, Dr. Rohit. Thank you, KSOS and Dr. Rohit Saxena for this opportunity. Can you see my slides?
Yes.
Yeah, Dr. Neena.
Yeah. So acute comitant esotropia, is it hype or a reality? That's the topic of discussion today. There are so many articles in the net as well as in literature about acute acquired comitant esotropia. So let me share a case scenario with you. So this is a 25-year-old IT professional who came to us with complaints of intermittent double vision since last 6 months. You can see, to start with, he's more or less straight, and as he starts to read the vision chart, he goes into an intermittent convergent squint. He's a myope, a minus 4.5 diopter. He's has a habit of taking off glasses during near work when we asked him. And he has an intermittent esotropia, which is more for distance than for near. And because of this, he's unable to drive at all. So we tried contact lenses for him. We atropinized him, tried giving him bifocals, nothing worked. Currently, he's on contact lenses and divergent stimulation exercises. The next option would be to give him prisms and see how he does, how he copes up with this. So the next case scenario would be this 15-year-old 10th standard student. Again, she came to us in 2020 during the COVID-19 lockdown. She was in class 10th and suddenly the classes had shifted to online stream and she had to copy down notes and attend classes for almost 8 hours a day. So there was a sudden onset of inward deviation of the left eye. You can see here, this is her previous photograph showing straight eyes and this is the left eye showing an inward deviation. She had basically a basic type of esotropia, which was similar for distance and for near. Everything else was normal, normal refraction, normal fundus. We even imaged her. That was also normal. Eventually, she underwent surgery and regained good binocularity and alignment. So the controversies in AACE. Should we evaluate these patients differently? Should we have a high index of suspicion or is it all unwarranted? What is the role of near work regulations, especially on gadgets? And when and how to intervene in these patients? Should we try surgery, orthoptic exercises, prisms, or Botox? How do we follow up and manage these patients? So I'll try to share my experience in this regard. So what is AACE? It's nothing but acute acquired comitant esotropia, self-explanatory. It's a type of acquired non-accommodative esodiviation, which is acute in onset, often associated with double vision, but comitant. That is, it's same in all gaze positions, seen in previously straight-eyed patients, usually presents in children. Burrion and Miller was the first to describe it, and it contributes to about 0.3% of childhood strabismus, but you can see it in adults as well as elderly. So classically, 3 different subtypes are there. The Swan type, which occurs after a period of interrupted binocularity. Then there is the Burrion-Francisci type, which is precipitated by physical or psychological stress and seen in patients with mild hypermetropia and diplopia, and the Belchevsky type seen in patients with myopia and convergent spasm and divergence weakness. Then there is the refractive accommodative type, which could have been missed previously, which is adequately controlled with refractive correction alone, and the less common type of intracranial pathology, most commonly a posterior fossa lesion. So we had looked into the presence of AAC in our hospital over a 3-year-old period, and we published this in Kerala Journal of Ophthalmology. From 2013 to 2016, we had about 12 patients, and about 8 patients had no significant associated systemic risk factors. They did very well with amblyopia therapy, and so eventually they had to have surgery. However, among these 8 patients, type 2 AAC was the most common, and the postulated mechanism would be the presence of a poor fusional divergence in them and something which would have led to the loss of this borderline fusion and manifesting as a non-accommodative comitant esodiviation. We also had one patient with overcorrected myopia who presented with esotropia, but when we atropinized the patient and gave the proper glasses on follow-up, the esotropia disappeared. So these were the patients who did very well with surgery. They were all having basic type of esotropia. However, we had 3 patients with systemic involvement. So one patient had viral fever preceding the onset of esotropia and recovered very well after 3 months. There was one patient who had ocular myasthenia on investigation and evaluation and did very well with pyridostigmine therapy. And there was another very interesting patient who was referred to surgery from Middle East. You can see this child had a right esotropia, and the movements were more or less okay, though I thought there was a mild abduction limitation. I couldn't elicit in any incompetence. However, there was a large distance near disparity. So they brought out this family album, which showed that he started squinting by about 5 years and it progressively increased. So the fundus showed a suspicious temporal pallor. We did an OCT. OCT showed temporal RNFL thinning. So there was something was not right, I felt. We imaged him and we found that he had extensive white matter lesions all over the brain involving bilateral optic tracts extending to the tectum of the midbrain and up to the pons on the left side. So the MR spectroscopy was done to confirm the diagnosis, which showed an increased uptake of choline with reduction in N-acetylaspartate very suggestive of low-grade glioma. And eventually he was detected to have neurofibromatosis 1 and a low-grade glioma. He's currently on follow-up. The parents refused a biopsy. Eventually, he underwent squint correction with me and he regained good alignment, though his right eye remains suppressed. So literature search, there are a lot of reports. Helena Brook et al. Had a case series of 48 patients over 13 years with intracranial pathology being in 6%, and they had good success rate with surgery. Shen et al. Had 47 patients over 4 years with 51% doing well with surgery. Kothari et al. In IGO had reported about 15 patients over 1.4 years and 40% did well with surgery. So we also had a similar case series. Recently, during the COVID-19 lockdown, we saw a surge in acute acquired comitant esotropia in young population. So that's what prompted us to do this study, and we published this recently in IGO. So in the last study, over 3 years, we had 12 patients. In the last 8 months, in this study, we had 15 patients. So that just shows the amount of increase in ASE. So the new norm of work, study, and play from home has changed everything dramatically. So we had, among the 15 patients that we had both myopes and hypermetropes. 33.3% were myopes, and we found that most of the myopes were having divergence insufficiency esotropia. That means the distant ESO was much more than near ESO, and it is fitting into the Belchevsky's type. Among the hyperopes, most of them had basic deviation, though some of them had divergence insufficiency also. There was one patient with moderate hypermetropia with esotropia precipitated by stress, whom you could say was fitting into the Burrian-Francisci type. But the only common factor in our series was that 80% of the patients were doing excessive neuractivity either on smartphone, laptop, or reading books. So that was the only common thing, and all of them had more than 8 hours of neuractivity. So we did a literature search. Lee et al. Had reported a series of 12 teenagers with ASE who use smartphones more than 4 hours a day. And in their study, they reported that the ESO deviation improved on refraining from smartphone use for a month. However, in their series also, 5 patients needed surgery. Yanbu et al. Reported a series of 26 cases over 20 months, and they postulated that there is a high risk of AAC with excessive near work, whether or not one wears glasses regularly, especially if they are a myope. So in their case series also, excessive near work was the target. Aldo Baghi et al. Reported a case series of 4 patients during the COVID-19 lockdown in Italy in 2020, and all of them spent about 8 to 10 hours per day using computers, tablets, and smartphones to play and to study, as well as to navigate social networks. So we also had a similar case series. So what is the etiology of this acute acquired comitant esotropia? We analyzed in our patients, and we think that the increasing use of smartphones and tablets in modern life has brought more and more work to the near, more and more work is done at the near platforms, and especially at small screens at a very close distance. And this excessive near work and a naturally stronger convergence in the young population leads to an imbalance between accommodation and divergences. The convergence being naturally stronger, there is a dynamic activation of the medial rectus muscle, and there is a development of a manifest esotropia. Now, if you're a hypermetrope, this is faster because they have a greater accommodative demand, as also seen in our study with 66% patients being hypermetropes. But what about the myopes? We normally expect the myopes to develop exotropia. How do they develop esotropia? Now, Belchevsky uncorrected myopia. If you have an uncorrected myope, you tend to hold books or text very close to the eyes, and that leads to an increased tone of the medial rectus, coupled with a lack of distant stimuli, leading to a divergence weakness and a manifest ESO deviation. Now, in our study, we found that whether or not the myopes wore glasses, they were at a higher risk of developing this ESO deviation because of the convergence excess. So take-home pearls would be that AAC can occur in older children, adults, and even in the elderly, you can get a divergence paralysis esotropia. So even though most of the patients are healthy, systemic diseases must be considered and ruled out before planning surgery. In children, prompt amblyopia therapy and timely surgery can result in a satisfactory outcome, especially in those with no systemic involvement. But the habit of long-term sustained near work, especially on smartphones, can induce AAC in young subjects, and parents and public health authorities should be aware of this negative impact on the eye health of the young population and give suitable recommendations and regulations to mitigate this undesirable effect. Thank you.
Thank you, Dr. Neena. We'll just go, you again put to rest some of the controversies that we have seen. So I'll just go around one or two questions which still remain a controversy. So Dr. Akshay, would you image every child who comes with a recent onset esotropia, which you would suspect in terms of an acute comitant esotropia?
So I think we are assuming that this is a non-refractive case where there is no hyperopia, but obviously we would rule out hyperopia. If that is there, then in clinic, we can actually do a few tests which can point towards central nervous system involvement. Simply something like a finger to nose test or a Romberg sign. If we check for these, we get a hint that we are dealing with a central nervous system involvement. And I generally tend to err on the side of imaging. If it's a young child with no explanation for the esotropia, there is no, the family albums are showing that it's an acquired esotropia, there's no refractive error, then I would err on the side of imaging.
So the first point Dr. Akshay has said that any child coming with esotropia, irrespective of the age, we should do an age-appropriate cycloplegic refraction. So that is the first step to eliminate an accommodative esotropia, which he's pointed out. The second controversy is about the imaging, and he's like said he errs on. Any difference in opinion? Anybody would, because of this huge number of cases, I'm sure all are seeing. Have you reduced your imaging? I for one still image all, but anybody has any difference? Like he's pointed out that if there is any other associated neurological sign or symptom, you kind of be more vigilant, but most of these children never had any. So anybody would defer or not do an imaging?
I do imaging in all cases. I just want to ask one question. Do anyone use Botox in these patients instead of surgery?
So the next option was botulinum toxin, the controversy, whether botulinum toxin would be adequate. Dr. Sandra had recently come out with a report on role of Botox, her experience. Yes, Dr. Sandra.
Yes, so as previously pointed, Dr. Neena, congratulations on a very nice talk on publication. And we have also been seeing increased number of children presenting with and young adults who are presenting with this acute comitant esotropias. So the reason why I started using Botox in these kids is because in very young children, they rapidly move towards suppression. So we are not doing very early surgery in these patients. So if we have to wait even for a period of 3 months, by the time they go into develop suppression, if that happens, we have seen even acute comitant esotropia in child as young as 4 or 5, because all of them are addicted. Addiction to smartphone is not limited to older age group. The patients in whom I use Botox is that we give this as an option when they present early, within a month or 2, and who have diplopia. The patients who have already gone in for suppression, I do not try Botox because I have tried in 1 or 2 and the success is not good. They get an esotropia again. So within this window period, if they present, then the first line of treatment that I'm trying now is Botox in very young children under a very short inhalation anesthesia, and in older young adults who are in IT professionals or anyone above the age of 15 under topical. And what in my experience, around 80% of the time, it has proved to be a cure, and there is no recurrence. For the oldest patients now, I am having over a year follow-up with no recurrence of the esotropia, provided we do advise them on not using the smartphones and the other good habits which we tell them, and we put them on rock string divergence exercises once they are aligned. So the alignment, if it happens by 1 week to 10 days post injection, and they get good stereopsis also back. And then I check their divergence amplitudes, which I have found in many patients are having divergence insufficiency. Probably that is what has predisposed them to develop the esotropia in the first place. So I proceed to give them the rock string exercise.
At what age or what time from their onset would you consider Botox?
Yeah, that's what I said, sir. Like if they present, so I image all the patients. So the first time they come to the clinic, if they present like at 15 days or 1 month time, I do an imaging in all of them. And also we try to ask them to stop the smartphone use for a period of a week and then get back. And in spite of it, if the angle remains the same, then I would consider Botox at around a month to 1.5 or even 2 months, not beyond that.
So, Dr. Neena, have you changed your surgical timing? I mean, normally we would have waited for at least 4 to 6 months in a case of recent onset strabismus. In acute combatant, would you, in children, have you reduced your duration of waiting before surgery?
Yes, I now usually advise surgery. I wait for 3 months and maximum 3 months. Like that young girl she was going to appear for the exam, the 15-year-old girl, I operated within 2 months because she couldn't concentrate on anything. She couldn't read and write, and she was going to appear for the board exams. And yeah, I operated in 2 months, but most of the other patients I wait for 3 months only now. If I'm convinced that it is not a neurological cause, no systemic involvement, no refractive element, and they're not doing well with orthoptics or prisms, we also give prisms to a few patients. So I operate now.
Great. So I think that thoughts are clear.
One observation I wanted to make is in this pandemic, we have found more cases of acute concomitant esotropia, and along with that, I have seen a significant myopia presenting for the first time, like a myopia to the tune of 3.5 diopters, which otherwise the child would have come much earlier. Now they come with such high myopia for the first time. So probably because their world revolves around the smartphones, they don't have to look at the board at the distance. They're not aware of having a significant myopia. That also I have found.
Plus, of course, the near activity of the past 2 years has increased the risk factors for myopia. So we'll go on to the third controversial topic, intermittent divergent strabismus, and I'll ask Dr. Sandra to give the introduction to the topic so that we can take a few questions post. Dr. Sandra.
Yeah, thank you. I hope you can see my slides. So, yes, I'll be talking about a very short presentation to give an overview on the intermittent divergent strabismus. As we all know, this is the most common type of strabismus that we see in our clinic. It's very common in the Asian population, and the onset is more than 63% of times it is less than 5 years of age, and oftentimes it can present less than 2 years of age also. So the Burien's and the Kushner's classification is what we generally use. The Kushner's has given additional points like tenacious proximal fusion, where after the prolonged occlusion, the near deviation approximates the distance deviation. High AC over A ratio. The AC over A ratio should be measured in all the patients who continue to have a smaller near deviation even after the patch. And sometimes it can be associated with a low AC over A ratio where the near measurement exceeds the distance measurement, and fusional convergence insufficiency and pseudo-convergence insufficiency types. So there can be various sensory adaptations to intermittent exotropia. Like whenever they are during the phoric phase, they can have hemiretinal, they can have bifoveal fusion, and during the tropia, they can have hemiretinal suppression. So the NRC can alternate with ARC, and in minority of them, they can have monofixation. Whenever this happens in the late onset, they present with diplopia. So in some cases, as we see, if we observe them over many years, they are stable. Some of them even improve, like if it starts very early on in age, if the visual acuity, they do not reach 6/6 in 2 or 3 years of age. But later on, as their visual acuity improves, the intermittent exotropia can also improve. In some cases, they remain stable, but in some cases, they do progress. So we don't know what are the reasons, though there has been several proposed mechanisms as to why these conditions continues to progress with age. There could be a decrease in the tonic convergence with increasing age. There could be a loss of fusion, secondary convergence insufficiency, development of suppression, loss of accommodation, and even divergence of orbit with increasing age has been proposed as a mechanism. So this is one child who presented to our clinic. As you can see, she is almost constant. She's age of 8, and she had an uncorrected vision of 6/18 when she presented first. With a 1.5 cylinder in her right eye, she improves to 6/9. but she did not have any stereopsis both for near or for distance. Binocular single vision is present for near when she's trying to fuse with great difficulty, but whenever she looks at distance, as you can see in the video, immediately the fusion is breaking. So prism cover test, there was a 35 prisms of exotropia for both distance and near. So in this case, I think what we would all agree that this is an emergent situation where we need to go in and operate at the earliest because the control is extremely poor. So in all these patients, when they come, we need to measure after a prolonged cover just to see if we are uncovering the full angle of deviation, and patch test for 45 minutes to 1 hour. Followed by, if the near deviation is still less than distance, measuring with a +3 near at to know about the AC/A ratio. And all cases, it's also a good idea to measure in the far distance. Control includes both subjective and objective methods, where we ask the patient questions regarding the home control and we assess the control in office. As the previous girl, we can say that it is a poor control, wherein it can be good or fair also. And objective methods also includes the measurements of distance and near stereopsis. So one of the methods that we use to assess the control is the Newcastle grading, where we have the questions for the home control, the near control, the distance control in the clinic. And if the Newcastle grade is over 4, then it could be an indication for surgery. There is another grading of control, the Molny and Holmes, where we observe the child over a period of 30 seconds. And we note that seconds where there is a deviation, and we can grade it from 0 to 5. 0 being pure phoria, where 5 is more than 20 seconds they are having a dissociation. Again, the choice of surgery would depend, like if there is definitely a true divergence excess, bilateral lateral rectus recessions would be the most commonly advised, which can be augmented. Certain surgeons advise augmentation by around 20%. And if we can add a Farden if it is a true divergence excess with a high AC/A ratio also. And in a basic and simulated divergence excess, you can choose between the bilateral surgeries or an RNR or augmentation. Convergence insufficiency is one of the most difficult to treat, where we can do a bilateral medial rectus resections or RNR also in some situations. And lateral incompetence, that is, if the lateral gaze measurements are less than 20% of the primary measurements, then you can reduce the surgical dose. Always address the patterns also. Surgical dosing is available everywhere. It's only a rough guide. And this particular table we have taken from Dr. Kekunaya's presentation in the publication in the British Medical Journal. And this would serve as a rough guide for surgery. So the timing again depends, like usually we try to push the surgery as much as possible and not operate immediately, because we need to quantify the amount of deviation, especially in smaller angles, to avoid basically consecutive esotropia, which will make them lose all binocularity which they possess, and that would in turn lead to amblyopia. So the ideal would be maybe over the age of 4 years. Less than the age of 4, only if there is a very poor control, with most of the times being constant. We have done a couple of cases, but then it is looking almost like a constant exotropia. Very rarely the child is fusing. Again, the target post-operative angle, it's again a controversy which we can discuss. Initial overcorrection can stabilize the post-operative alignment. In older children and adults, we can aim for orthotropia. So if you get a case of consecutive esotropia, then what do you do? If it is a very small angle, wait for a month and it may be beneficial also, because by the end of a month, the diplopia will promote the divergence and they will align themselves very well. But if it is a large consecutive esotropia of more than 20 prisms, we have to immediately give prisms, or we have to contemplate on surgical correction to avoid amblyopia. Prognosis in these cases always depends upon the length of follow-up. Immediately after post-op, it looks very well aligned, but as you follow them up over the years, it can regress at any point of time. High AC/A ratio, the surgical prognosis is poor. They can have overcorrections for near, and they may be candidates who need bifocal correction. So is it curable? Again, as I said previously, it depends upon the length of the follow-up, as several studies have previously published. Is it curable? It is one of the most simple conditions that we can diagnose, but it is one of the most difficult strabismus to actually give a cure to. So this is one more child which I would like to show. She's a 4-year-old with a vision of 6/6 normal refraction. She has binocular vision for near with distance suppression. Lang stereo 550 for near. Post patch, she shows a near deviation of 20, distance of 35. And with the +3 add, she is improving to 30 prisms of exotropia. So I would like to start the panel discussion on this question, that with the intermittent divergent strabismus with a near distance disparity, what would be your choice of procedure? And those with a high AC by A ratio, what would be the line of treatment? So this could be one, and there are several other dilemmas also that we commonly come across in intermittent strabismus, which Dr. Rohit sir can take up. Also, where do we look at non-surgical management, minimum age for surgery, target angle for different age groups, whether a small angle, single or two muscle, and do you prefer to put them on orthoptic therapy prior to surgery? And how do you counsel the patients on the possibility of progression and consecutive esotropia? What next? So thank you. It is a very controversial topic, in fact.
Thank you, Dr. Sandra. So we'll take up the key ones first. Would you overcorrect myopia in an intermittent divergent squint? Dr. Kavita, any thoughts?
Dr. Sandra, you can unshare.
Yes.
Yeah. Dr. Kavita, you're muted.
No, I would like to, as I mentioned earlier, I always try to balance visual acuity, patient's subjective correction, and as a doctor, our satisfaction. So I would like to balance between visual acuity as well as the squint, So if there is decrease in visual acuity, then probably I wouldn't want to overcorrect, or if the child is not comfortable. Then the binocular balancing between the eyes is also another thing after correcting. This is what I feel. I do overcorrect by 0.5, but then always keeping in mind the visual acuity and the comfort of the patient.
Okay. So, yes, Dr. Shubhangi.
Yeah, I've been just read an article, the resurgeries done for intermittent exotropia. So if it is an esotropia after the intermittent XT surgery, it was found that initial overcorrection got corrected initially, but at 6 months we should follow them at least for 6 months, because at that time the esotropia could increase, and the sensory situation is not good in cases of those having intermittent, those having overcorrection as against the residual ones. So maybe just a little overcorrection is indicated, but you don't want a larger overcorrection after intermittent.
Okay, so we were actually talking about refractive myopic overcorrection, but yeah, this is a point. So would you overcorrect? So anybody overcorrects surgically, creating a consecutive ESO in an intermittent divergence squint? Dr. Akshay, Dr. Kaushik? Jitendra first, he raised, yeah.
Yeah, I first wanted to comment on over minus. I think over minus is mainly to postpone or to get more time. So ideally, in a very young age, if you're seeing a child losing control, I would do over minus, but never in a patient whom I think that it won't help, because it is at the end of the day, if we want to buy time, we do over minus. So that was regarding over minus. So it is very pretty uncommon in my practice to do over minus. Overcorrections I do in most of the patients who are about 8 or 10 years of age. I do over correction in all the patients. Aim is to overcorrect by 5 prisms. I think I had my fair share of consecutive ESOs, but not many. So I think overcorrection, and we did a PG thesis on this, and over a period of at least 7 years follow-up, over a period of 7 years, we found that there is an exodrift of at least 8 to 10 prisms in almost 85% of the patients.
Right. In a small child you want. So how early would you go in and intervene, Dr. Akshay? If you have a child of, as was being talked, 1 or 2 years who's presenting fairly frequently with divergent strabismus, how early would you plan to go?
So I think what we ask the parents to do actually is to maintain a sort of a log at home as to how often they are seeing the child break out into a squint. Because what happens is if we are dealing with a 1 or 2-year-old child, when they come in, they're so anxious, they're crying so much that you tend to get a kind of a larger measurement than what the parents say. Parents say that they hardly see it at home, but probably because the child is anxious and crying, we are seeing them breaking out into a squint more often. So very rarely have I operated divergent squints at the age of 1 to 2 years, unless I'm convinced that it's actually becoming more and more constant and there's a pattern kind of associated with it. So it's very rare. Always I would look for a refractive error, try and treat that. If there's a fixation preference that I'm seeing, I'll take care of that by giving occlusion. And surgery for a 1 or 2-year-old would be something I would keep at a later stage, not immediate.
Okay. Dr. Kaushik, any thoughts on indications in a very young child? Any other indications you would think if you want to go in early?
Not really, sir. I think it's all been covered. Today, of course, we do use some amount of vision therapy also to kind of, like Dr. Jitendra said, buy some time. So it does seem to work. Children are a lot more comfortable working on devices today, thanks to COVID. We just finished a talk, but it does come sometimes to our advantage. So we do leverage that on and off.
So Jaspreet, before I just sum up and then give you the chance to go into your presentation. Yes.
Young patient, I was saying, I mean, like 2 years or 3 years coming with intermittent exo. What about alternate patching?
So that's a very strongly controversial. Okay, we'll just talk that. I'll give my views on 1 to 2-year-old or 3-year-old child. I would intervene if I see associated reasons why the child is breaking. So if there are oblique overactions, you know that they are not going to go away. It's actually very unlikely a small child who's probably moderately hyperope to actually, keep breaking. So look for other causes. There may be some reasons why the vision is subnormal. And as has been pointed out, if there's amblyopia, you treat that. So you need to first identify why such a small child is developing a divergent strabismus. It's rather uncommon for them to actually do. If he's an early onset myope, then you're worried. And alternate patching. Anybody tries or intervenes alternate patching in IDS, especially in young children?
Again, divide time.
Okay. I don't practice alternate patching because I would rather feel that you would want to stimulate binocularly as much as possible, because the aim is, unless there is evidence of suppression. So unless you're kind of documenting that there is amblyopia or suppression, I would probably feel that, stimulate binocularly would make more sense.
In some patients,
3 hours, not full day patching.
In some patients, in some small children, it will be very difficult to find out whether there is amblyopia or not. And in such cases, one eye will be dominant. In such cases, I give alternate patch, just thinking that in case there is an amblyopia, let it not progress. And then that alternate patch is only given for 1 hour a day.
Okay.
In those cases in which you have a suspicion.
Right. Okay. Yeah. So if you have a suspicion, exactly, it would probably. Dr. Kavita, okay, last word and then we'll go on.
I just wanted to tell the same points. When you're in doubt and you want to do something, you just can't leave the squint as it is. So to alleviate the apprehension of parents, we can try alternate patching, and it really works out well, and the parents are happy till we take up the child for surgery.
Okay, so we'll go on to the last one, managing congenital cataract, which is actually full of controversies, and that's why we kept it at the end. Otherwise, nothing else would have been discussed. Dr. Jaspreet will tell us some about his experience and about the controversies, and maybe we'll just have a few minutes after that for discussion. Sreeni is looking very angrily at me, so we'll quickly cover.
Thank you so much, KSOS and Rohit, for inviting me to this session here, and giving me this opportunity for something which is close to my heart. It's congenital cataract. So I have no financial interest in this presentation. So we'll just be covering up how we are going to go about dealing with some of the issues which everyone would have, people who are doing pediatric cataract surgery. So dealing with a child with bilateral cataract versus a unilateral cataract is something different, how you manage these children. So once in a cataract, when you've decided to operate, obviously cataracts which are significant, which are more than 3 millimeters, they're central, they're posterior and confluent, need surgery. And so once you've decided to do surgery because they are at risk of deprivation, amblyopia, what are the issues which come up in our mind? what is the optimal age in a neonate? Should we operate a neonate with cataract immediately or wait till the child is a bit older? What are our aims? Whether we go in for emmetropia, should we keep the child myopic or give him undercorrection? Should we implant a primary intraocular lens or keep the child aphakic and give a contact lens? What is the site of IOL implantation? Whether we should do it in a bag or we perform a posterior optic capture. Should we do a unilateral surgery versus a bilateral surgery because of the risk of general anesthesia? And what type of IOL can we implant, a unifocal or multifocal? So just cover up briefly on these things. Obviously, everything can't be covered in the short time. So timing of surgery is said that the best visual outcomes for a unilateral cataract are during the 6 weeks, because obviously the deprivation envelope will be much more in a unilateral cataract as compared to a bilateral cataract, which is 8 to 10 weeks. So it's more related to the patching and compliance. But if it's very early surgery, it can lead to glaucoma and inflammation. And that is why all non-essential surgery is to be done after 4 weeks post-conceptional age. Now, coming to whether we implant the IOL or keep the child aphakic, there are a lot of fors and against for the IOL and the contact lenses. The contact lenses are being favored by the infant aphakia treatment study, but then the advantages of intraocular lenses that it approximates the optics of the crystalline lens. You have a full-time partial optical correction. There is some limited data, but it is superior to contact lens in visual outcome, at least in the Indian scenario. With a contact lens, I mean, you could have poor compliance. Hygiene is a problem in India. Maintenance is cumbersome. But the thing is that you can easily change the power because of the myopic shift which is occurring. So this is one of our studies which we did where we compared the outcome of primary intraocular lens implantation in infants, and we followed them prospectively for 3 years. And as if we compare them to the infant aphakia treatment study, in our patients, we had a PCO of just 17% as compared to 40%. The pupillary membranes were much more in this group. Glaucoma was higher, obviously, because they were operating on children as less as 3 months or younger, but whereas we had high, you can say an elder age group, even though they were infants. And additional surgical procedures were 22% in our group, and they were 63%. So a 3 month versus a 6 month, this difference should not have been there. There's a high incidence of visual axis obscuration, which was the main cause of additional surgeries in the infant aphakia treatment study group. So then coming to the IOL power calculation, once you've decided that you're going to implant an IOL, there is a wider acceptance of implanting a primary IOL, especially above 6 months of age. And an acceptable age is becoming progressively younger. So what are the optimal approaches for an IOL implantation, right? The target refraction. So the refractive goal is the most important thing because we have a myopic shift. How much the myopic shift is going to be depends upon the age. For an infant, it's going to be much more as compared to a child who's more than 2 years old. What is the target refraction we are aiming for? It will be obviously a much higher undercorrection for a 6-month-old versus a child who is above 1 year of age. So we have to keep in mind the normal eye development because at birth, the axial length is around 17 millimeters and you have a steep keratometry. So these are all debatable issues. And most axial length elongation occurs in the first 2 years of life. That is why we have to undercorrect this child. The average shift has been 6 to 7 diopters in various studies. This survey, which is quite an important one, showed that keep about 4 to 6 diopters till the child is 6 months if you plan to implant a primary IOL and gradually decrease the undercorrection as the child grows. But avoid a greater than 3 diopters of anisometropia in older children. So this is one of our studies where we saw the myopic shift in children less than 2 years of age who had a primary IOL and followed them up till about for 8 years. And we found a myopic shift about 3 to 4 diopters in these children. So primary IOL implantation was helping us decrease the myopic shift. So because managing a pediatric cataract is going to be all surgical, so they are just the surgical controversies. Techniques of anterior capsulotomy, you could do a manual continuous curvilinear capsular access, you could do a can opener, or you could do a vitrexis. Some of them do use a fugo blade, but then whatever is best in your hand, you could do that. Then comes to the posterior capsulotomy and anterior vitrectomy. Now, why do a posterior capsulotomy and what is the age to do a posterior capsulotomy and when would you combine it with an anterior vitrectomy? So this is one of the most common debatable questions where the age becomes important. So all the cataract surgeries under age of 6 years probably need a posterior capsulotomy and anterior vitrectomy, whereas those above 6 years till about 8 years, you could just do a posterior capsulotomy without an anterior vitrectomy. Also, if you see the condition of the posterior capsule, even though the child may be 8 years, but if there's a dense opacity on the posterior capsule or a plaque, you need to remove that. And of course, if the child is uncooperative for GI capsulotomy, as you might be dealing with Down syndrome or issues like that, or patients with cerebral palsy, probably you would try to do a posterior capsulotomy in those patients during surgery. So because there is a high rate of PCO and fibrosis in children under 6 years, that is why you want to do all these procedures. And these are amblyogenic because the vitreous phase is also very reactive. So you have to combine it with an anterior vitrectomy in these children. Now coming to posterior capsulotomy, the techniques, again, it's like the anterior capsule. You could do a manual technique, you could do a vitrector-assisted capsulotomy, or you could do a radiofrequency diathermy. The goal is to have a 3.5 to 4 millimeter opening of the posterior capsule so that it does not contract or close by inflammatory membranes. For the optic capture, if you want to perform, which is prolapsing the IOL behind the optic behind the posterior capsule, the opening has to be a little larger. It should be central, and the best is if it's circular. So you could do the posterior capsulotomy and anterior vitrectomy before IOL implantation, or you could do it after IOL implantation. Now, if you do it after IOL implantation, you're safe because the IOL is in the bag. It's less stressful for the PCIOL fixation. You could have a larger capsulotomy size as well. But the disadvantage is the pars plana approach is the preferred approach. So you have to go to the pars plana, because if you try to go anteriorly, there is a risk of capsular stretching and risk of tear. No doubt it's very less, but the risk remains. Anterior vitrectomy, you could do a translimbar or the pars plicator route, wherever you are comfortable with. And site of IOL implantation. So the next issue is, where would you implant the IOL? I mean, the routine has been practiced that you would do a posterior capsulotomy, anterior vitrectomy, and put the IOL in the bag, as has been done in this case. And you can see this florid epithelial cells coming up. So this is almost a 5-year follow-up. Or you could just do a posterior optic capture. This is the other eye of the same patient. I mean, so no anterior vitrectomy was done. We prolapsed the optic behind the posterior capsule, and you can see a nice sommering ring formation. And everything is just all inside the bag. Nothing is just coming out of the bag. So this is a study which we came up with. Although the results were same between IOL in the bag versus in optic capture, the inflammation was more in patients with the optic in the bag. So incision closure, coming to the last parts of the controversial issues, people have said some, I just read a recent study where they said no need of closure. The study from India, probably, I think that is not the right option in these children because they are leaky. If you see the APOS members, just 2 to 8% leave them unsutured. We use more frequent steroid. We use, you can say, aggressive steroid use, which postpones healing. And self-sealing wound fail to remain watertight even in children less than 11 years. So it's always better that you suture these incisions. Bilateral simultaneous cataract surgery, maybe because you have increased risk of GA. Giving more GAs has been shown to decrease the cognitive, shown to have a cognitive decline in these patients. So probably it's a reasonable good option in patients where you're leaving them a phakic, but not where you're implanting with IOL. That's my personal opinion in these patients. And choice of IOL, monofocal, multifocal, again, obviously, in the younger patients, less than 6 years, probably multifocal is not really a good option because of risk of amblyopia, because you're having more images which are being formed. The neuroadaptation becomes difficult. The children are amblyopic, so probably a monofocal would be a better option in the younger children as compared to the multifocal. But again, we need some long-term studies, a prospective study to see what really is going on in these patients. So just concluding my presentation, I would like to say that refractive growth after IOL implantation cannot be predicted accurately, and current IOL formulas vary in the predictive outcomes. I haven't discussed the formulas. Refractive goal usually, again, less than 6 months, keep a higher under correction as compared to those more than 6 months. Operate for within 6 to 10 weeks and do a primary posterior capsulotomy and anterior vitrectomy in those less than 6 years. Bilateral surgery in COVID times, probably we were doing this surgery when the patients were being left. In those where the IOL were not being implanted, probably we were doing it for doing a bilateral simultaneous surgery, same time surgery. And primary IOL, no doubt, is becoming more favorable with the advancing techniques. However, all these controversies will require long-term prospective studies, especially in infants, for an answer, because we do have studies now for older children where primary IOL is the choice. But for the infants, yes, it still requires more studies. Thank you.
Thanks, Dr. Jaspreet. Just a couple of questions, I think, before we'll have to close. Any experience with soft contact lenses rehabilitation? The IATS compared it.
Yeah, so that was the reason. I mean, in our scenario, so these contact lenses are really not going to be very helpful because of the the hygiene part and getting lost, long follow-ups, patient come from far off. So it's always a problem. We don't have health centers or eye centers nearer to them who can deal with them. So probably that's why we said that IOL implantation probably is a better option in our case scenarios.
Anybody has experience on Dr. Leela? Yes.
Silicone contact lenses would have been good on the table, especially in unilateral cases. But then it is not available. Somebody said they can try and get it from, I don't know, no way that it is available as of now.
I don't think so. How early would you put in an IOL for unilateral and bilateral? So anybody in the panel, how early would you put in? Dr. Jitendra, Dr. Shubhangi? Yeah, Dr. Leela, please.
When in a unilateral case, I would occasionally prefer to implant an IOL even before 6 months. If all the other criteria are met, like corneal diameter, axial,
yeah, not non-ophthalmos and yes.
But not in bilateral cases.
Okay. Dr. Akshay, any difference? Your experience at LVP, how early would you put in an IOL?
I think for us, more than age criteria, we used to consider the anatomic factors. So if the corneal diameter was fine, and we used to do an on-table gonio also. If there was no indication that the angles were malformed or something, we used to put it irrespective of age. But yeah, anatomical factors are the most important.
See, in unilateral cataract, when you put the IOL, what is the power of the IOL? Is it you are planning the IOL to be?
So you want to, optimal, or you want to overcorrect? Dr. Jaspreet, what would be your preferred refractive post-op correction?
Again, depending upon the age, I mean, what's the age of the child?
6 months old.
So you have an infant unilateral cataract.
So if the infant is like more than 6 months of age, probably I would undercorrect by maybe just 3.5 or 4 diopters. But if the child is less than 6 months, in a unilateral cataract, I would, if the anatomical parameters allow me to implant an IOL, probably I would not go for above a 4 diopter undercorrection. Because in these patients, obviously the risk of amblyopia is high if you give them high undercorrection. No doubt the myopic shift is much faster in unilateral cases as compared to bilateral cases. But then again, for that period, I mean, even though it becomes a little more myopic, probably that will just help him with good vision. IOL exchange later on, again, you have to titrate that what the myopic shift is going to be later on.
Recently, I had a child, his calculated power was 39. We implanted a 30 diopter and he had plus 15 after surgery. And over 3 months, he came down to plus 5.
So what was the age of the child?
He was 3 months.
3 months.
And, highly unpredictable at that age. So
very unpredictable.
I think any comments before we close? I can see Dr. Sreeni staring down at me.
Gopal will kill me.
Do you look at the other eye status in unilateral cataracts before deciding on the IOL? I think that's also very important, no?
Absolutely. I tell you, I mean, I can go on like this. I'll tell you
I think just
minus 12 in the other end, what to do, and if you have a lens fairing, let me down in one eye, what to do. Hello, can you hear me?
Yeah, Jaspreet, we missed you in the middle, and I think we'll close now. I think there are congenital cataract, like I said, controversies would never end because we are still in process of learning so much.
Thanks, everyone.
Thank you.
Thank you very much.
Thank you, Dr. Thank you, Rohit. It's my mistake. I should have given you at least 1.5 to 2 hours. I'll compensate.
Thanks, Sreeni. Thank you for giving us the opportunity here. Thank you, KSOS. I think all of us really enjoyed. Of course, there's so much to discuss and enjoy, but all the best for your subsequent sessions. Hello, Gopal.
And see, we'll compensate. Like our next this thing series is on Pediatric Ophthalmology. So
do stay on Rohit with us. Do stay on with us. Yeah, हमने बहुत झेला तेरे को.
नहीं ऐसी क्या बात है बेटे? हमने एक दूसरे को यार 6 साल जेल रखा है. हमने एक दूसरे को 6 साल झेल रखा है. I think we know enough about each other.
Much more. 1990 onwards.
Oh yeah, of course.
Thank you, Rohit. Now we'll go on to our next session on retina. Dr. Gopal Pillai will be chairing that session, and Dr. Rekha will be the convener. And Dr. Rekha is a vitreoretinal surgeon from Trinity Eye Hospital, Palghat, and she did her vitreoretinal surgery from Shankar Nethralaya, and she's a prolific vitreoretinal surgeon. And Dr. Rekha, please take over and carry on with the session.
Thank you, sir. Thanks for the introduction. Can you hear me?
Dr. Rekha, you can cut off your video.
I'm trying to share the slide.
Yeah, no, but let me just introduce Dr. Rekha S, DNB and FVRs from Shankar Nethralaya, and former consultant vitreoretina at Vasan Eye Care as well as Agarwal Eye Hospitals, and senior consultant vitreoretina at the Trinity Eye Hospital, Palakkad. Rekha will introduce all our panelists. We have an esteemed group of panel, and after that, we will come in with the controversies.
Thank you, sir. Can you see my screen at present?
Yeah, it's you are sharing. It's just coming. Yeah, it's coming.
Can you hear me?
Yeah.
I firstly thank KSOS for giving me this opportunity to moderate this session, and the topic being very specific. The controversies in retina is very interesting, and it is very challenging topic, and it has to be handled by the stalwarts in VR. So firstly, I take an opportunity to introduce our chairperson, Dr. Gopal Pillai, who is a professor and head of the Department of Ophthalmology, School of Medicine, Kochi. He is the present Honorable General Secretary of KSOS. He is a prolific VR surgeon, and he has also written a minimal invasive vitreous surgery book, which each and every VR surgeon will refer. He worked as a junior and a senior resident in RP Center AIMS, and he was the right hand of H.K. Tiwari sir, and he worked till sir retired, and he has infinite number of national publications and 8 international publications and about 5 chapters in the textbooks. He's the present editor of Kerala Journal of Ophthalmology. With these few words, I welcome you, sir.
Thank you very much.
During this session, he'll be discussing all the scenarios of all these controversies, and finally, he will be giving us the final takeover from that controversy, so that becomes a practical tip to each and every VR surgeon in his routine practice. Now, I'd like to introduce our panelist, the senior consultant and head of the Department of Vitreoretinal Services and UVA at Center of Sight, New Delhi, Dr. Dinesh Talwar sir. He was formerly the professor of ophthalmology in RP Center AIMS. He has more than 100 publications in his crowd. Next, I'd like to welcome Dr. Prakash VS sir, who is the medical director and head of Department of Vitreoretinal Services, Comtus Charitable Trust Eye Hospital, Kozhikode. Next is Dr. Prashant Bhavankuley. He is the founder and head of the Department of Retina, Sarakshi Nethralaya, Nagpur. He has given a lot of orations in different ophthalmic societies, and he has the best award in the World Congress of Ocular Trauma in 2019 and Anand Saxena Gold Medal in 2018. At present, he is the treasurer of Vitreoretinal Society of India, the treasurer of Ocular Trauma Society of India, and the past president of Maharashtra Ophthalmic Society. The next panelist is Dr. Vinay Garodia. He is the medical director and the vitreoretinal surgeon in Synergy Eye Care. He is a prolific surgeon. I have heard a lot about you, sir. Dr. Sarvanan PR.
Thanks from Gopal.
And me also.
Thanks. Thanks.
So I am the junior person. Next is Dr. Sarvanan Vyasa, who is a professor and consultant at Arvind Eye Hospital, Coimbatore. He has a lot of national publications of more than 30. And I have seen his live surgeries recently, which was a terrific one. Next is Dr. Rajkumar Maheshwari. He's a medical director and director academics and senior consultant in Ahalya Eye Hospital. He has multiple national publications and about 8 international publications in his crowd. So I do expect the best results out of these controversies to come out and give a meaningful outcome of these controversies. And I like Dr. Gopal Pillai, sir, to take over and start the discussions. Thank you, sir.
Thank you very much, Rekha, for that generous introduction of all. Let us, can we just stop presenting so that I can start screen sharing? Can you stop presenting? Yeah, thanks.
I've done it.
Yeah. So without further delay, let us move into the controversies in retina. We have put together 6 different situations which we will be discussing. Situation number 1. Okay. We have a new kit called OCT angiography in the market, which is useful not only for diabetic macular edema, AMD, all those situations. OCT angiography is actually very, very useful now. Now you can look at these 2 pictures. In the upper one, you can see the fluorescent angiography. You can see the foveal vascular zone, which is so much well distinguished in the OCTA. Even the superficial as well as the deep plexus are very well seen. Like this is the other group, and you can see microaneurysms, etc. Now this is the other picture which shows the choroidal neovascularization quite well. So you can actually look at what happens to the choroidal neovascularization in a superficial layer, deep layer, based on the OCT angiography. You get much more insight into the pathophysiology than fluorescent angiography. The controversy here is dye is invasive, requires a crash cart. Patient may have anaphylaxis and even death has been reported. OCTA is faster. Nowadays, wide field OCT has come in. Should we completely replace fluorescent angiography with OCT angiography? So first, let us hear from Rajkumar. Rajkumar, can you first tell us your points? Then we will go one by one. Be short and crisp and to the point.
Yeah. Good morning to all. I have not experienced with OCT angiography, but at the same time, I don't advise fluorescein how I used to advise 10-15 years back. So I may not say that OCT angiography will completely replace fluorescent angiography. There is a place for fluorescent angiography. At the same time, OCT angiography is very expensive. Understanding of OCT angiography requires a lot of time, still evolving. So my point remains that fluorescent angiography stays, but the amount of fluorescent angiography requires number has come down. OCT is fine for many times because ultimate management remains same.
Sure. Prakash, so Rajkumar feels it is in the learning phase. What is your thought process?
Good morning, Gopal and all. So your main question was whether we can replace FFA with OCTA. I don't think it is possible because we cannot come. Both are for totally different purposes. So if an Opta gives a structural retina, it does not give the functional vascular anatomy actually. So what is the dye? What is the speed with which dye flows? What is the speed of retinal blood flow? And what is the dynamics between the retinal barriers, or inner retinal barrier, outer retinal barrier? This we cannot understand with a Opta. Whereas certain anatomic things, for example, a type 1 CNVM, a non-exudative AMD, these are much well visible on a Opta rather than an FFA. For example, another thing is you see a lot of microaneurysms in DME, but you cannot tell which layer it is. There is a different meaning for a microaneurysm in a superficial layer. If it is in a DCP, it has more chance of causing a diabetic macular edema. So that will information only you get from Opta. And again, if you come to uveitis and other conditions, there is no, I don't think there is a meaningful role as of now for Opta, whereas FFA gives us a lot of information. So we cannot replace. So that question is very clearly answered. We cannot replace FFA with OCTA. Then coming to the risks, as you told, if you are clear, we can reduce the risks by having clear indications for when you would do an FFA and when you won't do an FFA. So that way, that's the only way to decrease risk associated with FFA.
Vinay, any points? Vinay, any additional points?
No, I think I pretty much agree with Dr. Rajkumar. And again, since I don't have an OCT with me, and as he rightly said, it involves a lot of money and a lot of your own personal time as well. So, in a basic practice where you yourself are not doing OCT, just buying an OCT would not make sense till you are really dedicated towards dedicating some time to it. So that is it. But I think slowly the time will come and OCTA will become even more easily doable and cheaper. It will become the mainstay. But FA would stay.
Okay. Prashant and Saravanan, anything to add before I go to Dr. Dinesh Talwar? He has made one slide to end the show. Yeah.
Okay. As categorically pointed, in current scenario, there is no way OCTA can overcome FFA at this point of time. Even though you told that Whitefield OCTA is available currently in the Indian scenario, especially when there is cataract and poor patient compliance and cooperation, it is almost impossible or very tedious to take proper OCT, OCT angiograms of the periphery. Posterior pole phobia is okay, but periphery still a long way to go. Current scenario, no, definitely no.
Okay, so Prashant, can you tell us which are the situations where an OCTA cannot be used properly and a fluorescent angiography scores over an OCT angiography?
The basic difference is we cannot get a leak, be it a microaneurysm, be it a CSR leak, be it a diabetic retinopathy leak. So you can see a vascular front there, but you do not know whether it is active or not, whether it is a microaneurysm which is leaking or not, whether it warrants a treatment. So none of the treatment is guided based on an Opta findings. But yes, so if I have to look at my own practice, Opta, where you have to have lesion in the posterior pole about 4-5 disc diameter in and around the disc, well, even in a diabetic retinopathy, you can pick up a NVD, NV. In a CSR, well, you do not get any information. In AMD, you might get a information like a neovascular flaw, you can see. But the activity level, you cannot say. That is the only difference. Yes, there are different patterns of a vascular front which tells that these are probably active, these are probably inert. But we cannot be 100% sure. So as long as our therapeutics are not based on Opta findings, FFA is still a prime modality of management, rather investigating. So in my practice, though I have 2 Optas as well as FFA as well as ICG, FFA and ICG as a primary modality of investigation, as a primary, when a patient comes for a primary disease, is always done. And then subsequent follow-ups, subsequent need of repeat FFAs and ICGs definitely can be reduced based on that.
Okay. Dr. Dinesh Talwar, if you could share your one point
sharing
slide.
And I'm starting my talk. I'm starting talking also at the same time. See, basically, if the question had been FA versus OCT and OCT angio, you could have made life more difficult for all the panelists. But by making it only OCT angio, you made things very simple for them. In OCT angio alone cannot make all the diagnosis, but important things, specifically, even if you can see a CNVM in a OCT angio, a myopic CNVM, even with OCT, you cannot make a diagnosis whether it's still active or not. You still need to confirm with a fluorescein angiography. In a diabetic macular edema, you want to do focal laser. Knowing that there's a microaneurysm is not going to help you, even though microaneurysm is not going to be seen very well on an OCT angio. Merely seeing CNP areas in the macula will not help you. So there again, an FA is indispensable. Patients who have an active resolving or resolved choroiditis, that differentiation, fluorescein angiography does it better than any other procedure. And finally, in a chronic CSCR,
just the autofluorescence part of the fluorescein angiogram. The first picture that you take will tell you the extent of sick RP, which you can't see in other conditions. So just these small things can be a big difference in FA. Many places, FA can be replaced by OCT. For example, in CNVM, most of us people have stopped doing FA as a routine, except when they're suspecting PCV, when they do FA with ICG, or when you have a non-responding kind of lesion. So OCT versus FA is a better argument, debate than OCT angio alone.
Thank you very much, sir. Rekha, anything to add? Otherwise, I'll go to the next case. Okay, Rekha, you can go ahead.
Your old patient who had no history of floaters or flashes of light. He's a myopic of -4.5. Best corrected visual acuity is 6.6 N6. There are 360-degree lattices with without holes, and he is interested to go ahead with a LASIK surgery. So next. So do you want to go ahead with a laser in this case, or your option of doing laser varies with a different type of refractive surgeries? Or what is the timing of refractive surgery to be done after the laser?
So one of the major controversies that she brought in here in this particular case was that, we have a 360-degree significant lattices, completely asymptomatic in terms of flashes and floaters, no flashes and floaters. Patient comes for LASIK because he's 4.5 myope. Now, our question is, if we laser completely all comprehensively 360 degrees, there's a PVD which is going to be induced. There's going to be the PVD is going to be a little difficult because he's young, and probably we may end up having a tear or a retinal detachment, which is artificially created by us. So that is the problem. So what should be our approach?
You're scaring everybody by saying this. How often have you seen tears being created after the laser, if it's done properly, unless you do grade 4 laser burns?
Yeah. So that is again another point of discussion here, in the sense, how should we be lasering one small tear versus, when you are lasering extensively, how many rows, what would be your grade of laser, etc. So let us start with Vinay. Vinay, you are into practice, you are in Delhi, a lot of people coming in for LASIK. Yeah.
So I would do a moderate kind of a laser, 2 rows around it. And I like to wait for at least 2 weeks after the thing. And many times when you're doing such an extensive laser, you might do some missing also. So it's a good idea to review the patient after 2 weeks in case there are some leftover spots, cover them up. And as Dr. Talwar said, if you do a proper laser, the chances of complications are very, very low. So I would probably do that. As regards the choice of LASIK, choice of refractive surgery, we can go with whatever is best suited for that particular patient without much of a concern. Because if you do a good laser and if the patient has been asymptomatic, even the pressure during the creation of the flap is also not much of a deterrence there.
Okay. So, sir, Dr. Dinesh Talwar asked me whether I have seen a tear post laser. Yes, there are a lot of patients who start complaining of flashes and floaters, and I have also picked up maybe a couple of tears after a laser. So it is not that, post laser tears are not there.
No, I didn't say that. I said it's very rare.
Yeah.
It's a very rare thing. Floaters you will get. See, after all, you're creating a choroiditis. So you will get some increase in floaters over time. It doesn't usually result in a full-fledged PVD most of the times. The issue over here is, if you look at the theoretical basis, there is very little theoretical basis for saying do the treatment. Because even with lattice degeneration, the risk even in high myopes of the level of that's moderately high, which is the highest risk, 6 diopters and above. is less than 5% or so. The chance of getting a detachment over the entire lifetime is also less than 10%. But the question is, do I want to give a 5 to 10% lifetime risk if I can get away with it? So that is the real issue. Personally, I actually give with extensive lattices, I do go ahead and treat the patient. But I do it in multiple sittings. I don't do it in one sitting. I believe one sitting is not only painful, but also induces more reaction.
We are talking about a completely asymptomatic patient.
Yes.
No flashes, no floaters.
Yes. But he will become symptomatic after the laser.
Huh. Yeah.
One of the reasons why he may see floaters is because you've primed him to look for floaters, So the regular floaters also he may start to see. So, floaters will be very, very common. Yeah.
Yeah, Saravanan wanted to.
Yeah. Thing is, there is a lot of published evidence, especially from the South American countries, that doing a refractive surgery does not incur any additional risk for developing tears or RD. So in this scenario, you have categorically put across that whether to do barrage laser just because the patient is undergoing refractive surgery. That is categorically no, because there is no support, evidence-based support for that notion. Apart from that, I have also seen, especially in pediatric cases where laser has induced secondary tears and even RD asymptomatic patient going in for significant complications. We have seen the reason being that as you move towards the periphery, especially near the lattice areas, the retina is much more thinner, and in the syndromic eyes, the vitreous is quite tough and much more adherent, and the post laser contracture can produce secondary tears. So especially in syndromic situations, the risk of developing tears, especially in the presence of extensive lattice degeneration and thinning, is much more higher than routine lattices. So in those cases, it's better to avoid, especially if there's no history of family history or no holes or tears present. As regards to refractive surgery, I think there is no support for evidence-based support.
Okay, so that brings in a real controversy here. Like Dr. Dinesh Talwar and Dr. Vinay are of opinion that we are going to laser a 360-degree lattice, whereas Saravanan is saying that there is no evidence that lasering will, or even refractive surgery will actually produce a retinal detachment. So he would not laser.
But he put a rider there. Mm-hmm. He's thinking in terms of syndromic situations in pediatric. This thing. The question is
that was the answer for secondary laser-induced tears. But for refractive surgery, no asymptomatic, no family history, I would not, definitely not.
I agree with Saravanan partially because, as I said, that you can do any kind of refractive surgery. So I didn't ask for a PRK fearing. So that there I agree with Saravanan that refractive surgery doesn't increase the risk of detachment, but I would laser the lattices either ways. So that's where I differ.
Okay, let's hear from Prashant.
Yeah. See, the issue is not, it is very clear. You said minus 4.5, it is a non-syndromic eye, young patient ready for a refractive procedure. Is the refractive procedure adding to the risk? We also know, we all accept when every literature has enough evidence to say that it does not induce. But remember, 1% can have a persistent corneal haze and all these things. And if ever in this course of time, if this patient has a coincidental, not I should say procedure-induced changes in the lattice leading to further it can lead to a detachment where we are not able to reach out. So why not be safer by doing and reassuring and completing? Regarding creating a break because of the laser-induced, as Talwar sir has very clearly said, the type of a burn and the distance away from the lattice is more important. So wherever there are vitreous adhesions, you have to be at least a 1 or 2 disc diameter away. Many times what we see is people do a laser right into the lattice. That is what induces predominantly, because vitreous adhesions have to be adhered. That is what the message should go.
Yeah. Prakash and Rajkumar, any additional points?
Actually, the fact is it's not as far as the risk of increase of RD following LASIK is concerned. It's not increasing. The question is, though that is only theoretical. It is a theoretical risk that the suction occurs. It can increase possibility of tears and all. But practically speaking, in the real world, as Saravanan said, there are very few studies which have shown any increase in that risk. The question, so actually it boils down to, would I laser a patient who has multiple lattices anyway? Now, this is where I have a sort of I go in a top-down manner. If single lattice, I don't care. I'll leave it alone, even with or without hole. Single oral lattice, again, no intervention. Equatorial lattices, I would be more, I think the risk of fraction increases, I would consider. Perivascular lattices, the risk goes up further. Lattices which are in patients with 6 to 8 diopters of myopia and above, up to 10 diopters, the risk is highest. I would definitely go ahead and do the laser. And if you actually feel that there are a lot of adhesion, the syndromic varieties, patients who got lot of these areas of peripheral traction, I would avoid. There I would avoid for a different reason. Their laser precipitates breaks. Whichever breaks I've seen following laser and then an RD following that have occurred in patients who either had some kind of a syndromic thing where there was peripheral traction, somebody lasered, that laser induced a break. So those are the cases where laser should be avoided. And that is very important to recognize, even if there are extensive lattices.
Okay, sir. Rajkumar wanted to say something.
Yeah, hi. I agree with Sarwan sir that
Rajkumar, tell us.
Before LASIK, not to do PRP, Parag laser, I will not agree. I will always ask them to go ahead with the LASIK surgery. And then most of the time people are shifted to PRK and transepithelial laser excimer surgery. So it really doesn't matter whether pressure is increased or not. The second thing, specific to this case where there is extensive 360-degree lattice, I will always explain to the patient what they are encountering. And there is a very high chance that later on in life, if the PVD happens naturally, the retinal detachment is going to be very bad. So suppose if you have done barrage laser for this patient, managing retinal detachment in this kind of patient will be easier rather than dealing with a 360-degree peripheral PVR and then ultimately having detachments and all those things. So for this patient, if careful laser barrage is done, I think the patient risk of developing complicated detachment will be very, very less. So I will prefer barrage laser, careful barrage laser. One more point, when you do 360-degree barrage laser, there is chance that long temporal nerves can be hit, and then patient can have mydrosis, which we have seen in 2-3 patients. So that we have to be careful when you are hitting on the periphery, especially 3 o'clock and 9 o'clock area. So this is my take on actually.
Loss of accommodation can occur in these young people. Yeah. So the world is divided as far as laser or no laser is concerned. But if you have to do a laser, probably you have to have grade 2 to 3 burns probably, and maybe 2, maximum 3 rows around it, and give a little space so that acute PVD does not develop, and leave the 3 and 9 o'clock always.
Space between treatments, not the burns.
Space between the treatments, yeah, so that PVD doesn't develop so easy. You don't have anything to share here, sir? Okay.
No. So syndromic lattices should be treated or not?
Syndromic lattice,
I would watch them. I would keep
syndromic lattice. Yeah, syndromic lattices and all. I think we have an option of saying, okay, no to refractive surgery also.
So especially if one of the eyes has developed RD, I would go for a prophylactic buckle in the syndromic lattices rather than going for a barrage. Barrage is more risky. If one eye has developed RD and you want to do a prophylactic treatment, I would go for a prophylactic buckle, especially where there is almost all around 360-degree lattice in a syndromic situation.
And what would you do, Sarvanan, if the lattices were going almost till, say, 2 this diameter from the arcade?
So the very posterior lattice, obviously, buckle will not help. But I feel that the peripheral traction, I have done buckles for cases where some of the lattices are extending posterior to the equator, but still I go for a sort of a wider buckle, 276 or 277, which helps to support, especially in children where the other eye is lost vision because of RD. I prefer a prophylactic wider buckle in these cases.
Okay. So one more time, let us move to the next case.
Can I summarize? I think all of us are agreeing on that point that refractive surgery doesn't make any difference to the treatment, whether what we are going to be doing, right? So that's one thing all of us agree upon. Yes. Now, the next question is that we all agree that the risk of detachment in an asymptomatic lattice is not very high. But as Dr. Talwar put it very clearly, that do I want to take that risk even? So we have to basically weigh the risk of laser vis-a-vis the risk of asymptomatic lattice. And if a good laser is done properly, the risk of laser is much lesser. Therefore, we like to do a laser in these asymptomatic cases as well. I think that is what I would like to summarize. There's no controversy left, I think.
Okay, so let's move to the next controversy.
I think Sarvanan is on the other
Let's
side.
move to the next controversy.
Yeah.
In diabetic macular edema, as we all know, there are a lot of patients who have high hemoglobin A1C, poor systemic control, hypertension, etc. And you have to keep on injecting in some cases because they have visual needs as well. So this is a case in which you require to inject again and again and again and again. And so what is the point of time? Can we define poor response, non-response? When do you say it is recalcitrant? When do you say it is chronic DME? And what is the point of time after how many injections are we going to switch the anti-VEGF agent? Are we going to switch to another anti-VEGF, or are we going to switch to steroids? Are you looking at some OCT biomarkers? What about Paganex and addition of focal laser by PRP? So let us start asking by Prakash. Prakash has been silent throughout the last discussion. So let this question be answered initially by Prakash. So what is your definition of a non-response, poor response, chronic DME, etc.?
Gopal, you introduced this question with saying that we are a patient with anemia, chronic renal failure. So you mean after systemic control, you want the question to be answered?
No, all these are simultaneous. Many of these patients, the systemic controls, factors cannot be completely controlled. We will do as much as possible to control it, definitely, but it is an ongoing simultaneous treatment. We can't actually ask them to, go control and come. He will never come back.
So I'll tell you what, I'm going to make your question easier because you're confusing the panelists. We will all—
That is the basic idea.
We will all take care of all the systemic parameters concurrently with management of the eye. So now how do we want to manage the eye while the systemic parameters are being controlled?
That is better. That is better.
Right? So
that is better. You cut off a lot of.
Prakash,
that's good.
We can take it up.
Yeah, so
otherwise, somebody will talk about controlling renal failure and somebody will talk about controlling.
Exactly.
No. Let that all be controlled. Okay. Now let us come only to the eye.
And God said, "Let there be light."
And we are also ruling out any VMT factor also. So let's also remove that.
Sure.
So
that's also
not there.
That's also not there. Pure DME.
Yeah. Pure DME. So Gopal, actually, everyone would agree that it will be first line of therapy would be anti-VEGF in these eyes. Most of us would go with anti-VEGF treatment. So when you call, most of us will go for a monthly treatment till we get the maximum response. So that is a protocol what we follow. And when will we call it a poor response? I would call it a poor response if there is a less than 20% response on OCT at 12 weeks or less than 5 letter improvement at 12 weeks, which is a standard followed in most of the studies. So whether you want to call it this at 3 months or 6 months is again, some of the studies have used 6 months as a criteria. Some of them have used as after 3 injections. So the main thing that you have to understand is we clearly know there is enough scientific evidence to tell that earlier the response, the better visual outcome for these patients. So it is better we call it slightly on the earlier side because so that we get the best visual outcome for your particular patient. So I would prefer to call it a poor responder at 3 months of after 3 injections, that is 12-week treatment. If it is not showing satisfactory improvement, that is less than 20% reduction in OCT. So many studies have even gone up to 1 year and 12 years, but I don't know what is the point in getting a 20% reduction after 1 year or 2 years after giving so many number of injections. So the earlier we call it, the better.
Okay, Prakash, may I just interrupt here and ask all the other panelists if there is any difference in opinion regarding 3 months decision on poor response? Or do you want to wait for, Rajkumar, you want to say?
Yeah, in our practice, if we are explaining patient to different anti-VEGF injections, there are a lot of expense involved in that. And then suppose patient is not seeing any response in 3 months time, they will not come back to us. So I'll be a little early in saying non-response. The first injection, I see not much macular edema resolution. I'll prime the patient and tell them that the amount of response I was expecting, it is not there. I'll try one more injection and see whether it's responding. If it is not responding, maybe third injection, I'm going to change. So I'll be priming the patient so that he also understands what is going on, because it is not entirely on us. And I'll be giving all the options. This is anti-VEGF, this is safest. And if I go to steroid, there's a chance of glaucoma and cataract. So I'll be priming. At the same time, patient will also understand that there is a chance that it may not respond. There is a chance the injection is changed. So I'll be priming, but then I will not be waiting for 3 months.
So you'll be counseling the patient, but generally your thought process is also 3 months. But you'll be priming the patient for that before that.
No, not 3 months. So if I second injection,
2 months. Okay, by the second injection. Okay.
Second injection, after second injection, I'll be saying after 15 days, and if I see it's not improved, third injection, I'll go with steroid.
Okay. What do the other panelists say? 3 months, 6 months, 2 months?
I agree with Rajkumar. Sorry.
Yeah, please, sir. Please.
I agree with Dr. Rajkumar about starting to prime the patient 1 month in advance. That's a very, very valid point, especially if thinking about switching to steroids. To tell them, let them do their own research about the potential risks of glaucoma and everything. And again, I would also give 2 shots in the third injection. After third injection, I'll try to change. But in case I'm starting with ranibizumab, I may even think about switching over to Eylea in the second shot also. So it also depends upon the agent that I'm using. So that is one thing that I would differ slightly.
So after 1 injection, you will switch. You will
if the first injection is showing me no response at all, ranibizumab, if I've given, I may think about switching over to Eylea in the second injection also, if the patient can afford.
Everyone then. Most of the people will not show that kind of response.
So there's some response does come in with 1 injection. Some
but there's a very large number of people who would need to switch then. If you're,
then you start talking about Eylea to the ranibizumab patients in case they are not responding, and you give them the options of steroids for the later. So again, patients have asked for ranibizumab anyway are not going to go for Eylea because there are financial issues.
Why should we start with ranibizumab? Why can't we start with Eylea itself?
I mostly start with Eylea, but if the patient can't afford,
cost also now it's almost same.
No, but
so
still for the Indian ranibizumab is much cheaper than the. So I've almost stopped using eccentrics at my place.
Okay.
I'm either using Razumab or I'm using Eylea. So those are the 2 categories that normally.
Sure. Prashant, you wanted to say something?
Yeah, I'm presuming this discussion is after we have investigated the patient with fluorescein angiography and OCT. I need not be necessarily using an anti-VEGF. I might use, if there are certain biomarkers, OCT biomarkers, which indicate more towards inflammation, steroid can be my primary line of management. Call it HRDs or say it SRD, a pseudophakic patient. There I might have my first choice as a steroid as well. Be it steroid, be it anti-VEGF, whatever molecule we are using, if I'm not getting a sufficient response, I would definitely at 3 months repeat an angiogram once more. And with wide field angiograms, many a times you might see ultra wide field angiogram, you might definitely see certain peripheral dropouts and all those things, which needs to be adequately treated rather than just playing with the anti-VEGF and jumping from one anti-VEGF to other or going for a steroid. I don't think that is logical. We should reevaluate the situation before we call it a resistant case.
Okay. Saravanan, you also.
Yeah, more I go with the Vinay sir's. Most of the criteria I follow is very close to Vinay sir. 2 injections. If I'm not seeing even a 25% reduction, then I would term it as a non-responder. Apart from analyzing for other diagnoses, but for Prashant sir's notion, again, there is no evidence-based support. Even though clinically we also do peripheral PRP to aid the activity of injections, there is no evidence-based support to show that peripheral PRP shutting down the non-CNP areas in the periphery helps in management of DME. But otherwise, I go with almost what Vinay sir said. That's what.
Okay, let me first add that. Let me give support to Prashant because the biggest study which says that PRP with anti-VEGF is good for reducing macular edema is actually the protocol S. If you see the number of injections in the PRP group with in which the anti-VEGF was given and PRP was done, the number of injections came down by half. Okay, so actually that is the strongest study we have for saying that PRP does help to bring down the number of injections. At the same time, I would disagree that you don't start off with the PRP. I mean, if the main thing is DME, I'm not going to start off with PRP. Only after, say, 6 months into this treatment, I will consider whether I'm missing out peripheral CNP areas which need to be looked at. So that's a separate issue. But now I want to set the cat among the pigeons. May I show a slide?
Yeah, please, sir, please. We are 5 minutes delayed. So we should be making out that 5 minutes in the next 25 minutes.
This is
Gopal, this is exciting. Like, don't worry.
This is a study of intravitreal ranibizumab and dexamethasone combined treatment in treatment-naive patients versus monotherapy with ranibizumab. See, so far you talk of protocol U, and there you keep on talking about persistent macular edema, not responding, etc., etc. Look at this. They took two groups. One group got both anti-VEGF and steroid. The other group got only anti-VEGF. And see the results. I mean, these are mind-boggling. In the simultaneous, what they call the simultaneous double protocol therapy, that means steroid with the anti-VEGF, 21 letter improvement at 1 year compared to 9.8, which is the usual kind of improvement you expect in the monotherapy group. Number of patients getting more than 3 line improvement, 60% versus 30%. 30% is what you would normally expect. 60% is what you got in this group. The important thing here is that they gave the injection of steroid either after the first injection or after the second injection of ranibizumab. So now, based on this, what I would say is you start off with anti-VEGF. You have 25% patients who are with ranibizumab who are going to do beautifully. They will improve within those first 3 injections, and they don't need to be shifted. If you started with aflibercept, the figure is 50%. That is from the protocol T. 50% of patients will get more than 2 line improvement within the first 3 injections. Don't need to be shifted. But the rest of the patients, by the 3rd injection, consider adding Ozurdex to these patients. The results will be more or less, we can expect something like what they are doing. If we can, that's a huge improvement. The important thing is that the improvement continues to occur through the year once you put the patient on this combination therapy, rather than saying I'm going to do sequential therapy, which I used to do also previously. So this is something I wanted to put this cat among the pigeons and let this panel see this. And you can see within 3 months, more than 10 letter improvements occurred. Within 1 month, after they've given the Ozurdex and the steroid and the anti-VEGF, 1 line improvements already occurred, and by 3 months, that improvement has occurred to beyond 2 lines. So this is the important thing here, which I wanted to share with you. I saw this study and I found it fascinating, and I think it's worth considering in treatment-naive patients. Now, for me, always it has been not 3 injections, but 3 OCTs and vision status, no change, is an indication for going in. So it could be first pre-treatment OCT, no change from that to first month and second month. Then I would shift at the second injection itself, I would add the Ozurdex. If in the first 2 injections I get the response, don't get any response after that, then I would wait for another OCT. So 3 consecutive OCTs, no change, is an indication for adding steroid. Over to you.
Gopal, can I add one more point?
Sure, please.
Like we have actually, just like Talwar sir showed, there is a real, another very nice actually study of real world evidence on switching to at 12 weeks, switching to Ozurdex. If you look at the real world evidence from that study, that's cited by 29 or more people. It's a very nice study actually. It shows that there's a significant, they have compared actually after 3 injections, they have compared switching to Ozurdex versus continuing on anti-VEGF. So it clearly shows switching to Ozurdex at 3 weeks. If it is a poor responder, if you switch to Ozurdex, the results are far better than almost 7-8 letters difference rather than continuing on anti-VEGF alone. So that is a very, very important thing. I feel you should not wait and continue on anti-VEGF, rather switch at that point.
That point is taken. So even in treatment-naive patients, when you treated with Ozurdex, they had 14 letters of improvement with significant less number of injections. But let me ask you this question to the esteemed panel: Can we have a show of hands? How many will shift to Ozurdex within the first 3 months of starting treatment for DME?
Can I ask a small question before that, Gopal? I just wanted to ask Dr. Talwar, would you recommend switching to Ozurdex or adding Ozurdex? Because I think you said
Very
adding
good.
Ozurdex.
Vinay, that's a very important thing, because here it is that you'll add the Ozurdex. Now, this is something that I've been following for years. You add the Ozurdex, you follow up monthly, but the moment you see any, as long as it's on a downhill thing, the thickness is going down, nothing to be done. The moment you see that trend reversing, please add an anti-VEGF, because otherwise you're going to get a rebound and you lose all the gain that you got from Ozurdex.
Yeah.
And that rebound can occur anytime between the 3rd month to the 5th month.
Actually, I've been doing that in 1 or 2 recalcitrant kind of cases where I've added both together, but I don't, again, I probably would not have the guts to start it from day 1 with Ozurdex.
So it's not day 1. I'm not saying day 1. I'm saying you give your first 3 injections. If in the first 2 injections you've been getting response, then it gets delayed by another 2 injections. But if you got no response in the first 2 injections, the 3rd injection you can give both together.
I was talking about the study that you quoted, and I think
but the treatment I modified the study a little bit because we want to take advantage of the 25% of ranibizumab patients and 50% of aflibercept patients who will respond in the first 2 injections. Okay. Why should I lose that benefit?
Okay, sir. Should we move to the next controversy because of want of time? Because this requires much more introspection, and we will probably discuss 1 hour this particular topic only.
This is a full CME topic. This was a full CME topic.
So let's go to this case. Rekha, you want to take this?
Gopal, this is not technically florid PDR. This is
technically non-florid PDR. This is the picture. Technically non-florid PDR.
Because there's a difference between the 2 things.
Yeah. So this is the PDR in front of you, sir.
Yes.
He has 6x6 vision. Rekha.
No, but what about the lower one? That's the...
No. So because this is my patient, I'll talk about this. So this patient had 6x6 vision. Other eye is already lost. And this is the vision, 6x6. Now, if I do pan-retinal see, the other eye also had a proliferative diabetic retinopathy, which was lasered elsewhere, but immediately post-laser, he developed a bleed and traction retinal detachment. And finally, that was operated in that particular place. And finally, the patient ended up with no PL. So this patient is very skeptical about laser in this particular eye. And we all know that if there is a proliferative diabetic retinopathy, it is better to be lasered. And this is like follow-up over each year. Like after this is also 6x6. This is about 6x9 with a traction band, which is coming here. And then finally, he bled in the 4th year when we had to intervene. So with multiple peripheral traction with very good vision, there's a chance of progression of traction retinal detachment and bleed with a pan-retinal photocoagulation, and not so well done pan-retinal photocoagulation, I should confess. Okay, basically, if you come very close to the arcade or if you are doing heavy laser, etc. And immediate post-PRP, there could be a loss of vision, and waiting and observation may progress slowly. So in such cases with multiple tractions in the periphery, with multiple florid neovascularizations in multiple areas, should we wait or should we go ahead with laser? Prashant, I would ask you first.
There is no second thought. 1 eye lost, and this eye having such a florid PDR. You have to explain the patient the necessity of the particular treatment, which would be definitely helpful to you intraoperatively later on, whatever time. Importantly, 15% of this extrafoveal tractions do come into foveal region. That is the rate. 15% migrate means rate of progression to involvement of macula. So if you take the patient into confidence and with his fear of having already lost other eye, I don't see any reason why he would not accept a PRP. Sorry.
Okay. Saravanan, yeah.
What current trend, what I follow is like this case, especially in our population, a lot of people coming from far off and not very compliant. If I feel that down the line, this patient is going to need surgery, I do it right away. Even before doing PRP, right away, I take it up for surgery. And if when news are very florid, I would give 3 days, 5 days before I'll give a Avastin injection and take it up for surgery. That is my take. That's
no vision drop.
No problem. And vision is not a criteria for me. If I feel that down the line this patient is going to go for tractional complications, I prefer to operate right away, even before doing laser. That's what we are following in our hospital right now.
Okay. Gopal, even I feel this particular case that you have showed, already there is traction, there is on the disc, it need not be subhyaloid hemorrhage or TRD. This chronic distraction itself can cause loss of vision. So it is better to take up this patient, especially one eye is already lost. I would prefer to go for surgery in this case after an intravitreal Avastin, of course.
Prakash, I would disagree, because this patient does not have any symptom in this eye, in this particular eye.
Currently is not having symptoms. If you look at the criteria for treatment, like laser criteria for CSME, vision was never criteria. We had only 3 anatomical criteria. The meaning that tomorrow this patient is going to lose vision. If you look at the CSME focal laser criteria, vision was never a part.
No, but
these patients can still have 6 vision. Vision was never a criteria in these patients. So we are looking at whether the patient is currently lost vision or he has got a risk of losing vision down the line. That's the vision can never be a part in making decisions in these patients.
Should I make him blind now or after 10 years?
See, this is a patient who's even scared of a laser. And then you're talking about doing a surgery to a 6x6. Theoretically, I agree with you. I would probably also like to go in, but practically, I don't really see this patient agreeing to the surgery. And if the patient has done badly in one eye, it is very likely that he might do badly in this eye also. So
that is following laser. That's why I'm saying right now, when the membranes are simple and the adhesions are lesser and the retina is much more thicker, better to go for surgery. The chance of complications is much more lesser. Surgery is going to be much more simpler. Rather than waiting, doing laser and allowing the traction to produce retina will become more thin. The traction has become more severe. So your surgical outcomes is going to drop down when you operate like after 1 year or 2 years or even.
So I think I should take a lessons from counseling from Saravanan actually. It's absolutely amazing.
I think we need to be.
Is this patient IDDM or NIDDM?
Or NIDDM.
Exactly.
Type 2.
So do you know? I think one thing to keep in mind, even in patients who had vitrectomy for a DME, there is a 20% risk of losing vision because of the nerve being not okay. So you're talking of patients, and we know that in patients, of course, if you go to the DRVS, we know there's a 20 to 25% risk of no light perception.
Sir, DRVS is
DRVS is 1970s, sir. Please, sir, let's not take that into account.
I am just pointing it out to you that you may talk of 23 and 25 gauge surgeries, but the fact remains that these surgeries are unpredictable. The extent of peripheral traction can be more than you expect. I have burnt my hands on this, going in a patient with 624 and ending up with 660. So the point is not that. The point is, and with a normal fundus, the normal looking fundus, no problem in the fundus, but unfortunately the vision's gone down. So the basic thing is, I agree with Saravanan that technically, it's very, very tempting to go inside and remove this membrane, because you can actually see that there is a plane available. You can go inside and do the surgery. But there are, and I can give you a recent example where I had this kind of thing where I thought it was a lot of plane was available, and it turned out to be a completely adherent retina membrane, which took me 3 to 4 hours to remove after that. So sometimes you can get badly burnt when you think that is not too difficult. This one point. The second thing is, if this patient has areas which are not under traction, those areas can slowly be lasered first before going in for the surgery. If at all you want to think in terms of surgery also, you can, and you may be able to stabilize this retina. See, right now, the reason why you had this progression over these years was because actually the peripheral neovascularization was progressing. The CNP areas were progressing, they were all there. So there was a continuous VEGF production, which kept on increasing this the fraction over here. But what if you had done slowly laser in that area, which is not, and you know what happens? Sometimes you clinically look on the indirect, it looks a lot of areas there which can be lasered. But when you see on a 90D with your slit lamp, you find that there are areas which have a shallow RD. Those have to be avoided completely. Otherwise, the progression is more severe. So if you can slowly complete the laser in the completely attached retina, and then you can talk about whether this is still progressing. If it is still progressing, like you could see in your case also, year by year it was progressing. If the progression is occurring, you can consider doing the surgery.
Yeah. Yeah, I waited for the vision to drop. That's all. Okay, Prashant.
Gopal, yeah, I think we need to understand he needs a urgent PRP. That is for sure. You can space it so that it doesn't induce edema into macula by spacing it about a week later, second, third sittings. And with a low threshold of vitreous surgery. Means earlier, what happens is peripheral tractions also get stabilized because of the anchoring effect of the laser tractions.
Okay. Okay.
So
if all the panelists, actually agrees to this, so PRP is needed. We'll do it slowly, but Saravanan will say, early surgery. So very low threshold to surgery. Is that okay?
No.
Yeah. Rajkumar wants to say something.
Yeah, Rajkumar. Yeah.
Gopal, we should never forget that. Yeah, I'm sorry. We should not forget that we practice in Kerala and Sarvan practice in Tamil Nadu. There is a lot of patients.
And he gets patients from Paro. Even if he gets patients from Kerala, it doesn't cause problem for him.
When Kerala patients goes to Tamil Nadu, they become very decent patients.
Kerala only
you and me still have to practice in Kerala. They will not forgive you if this surgery goes wrong or if they develop bleed or peripheral detachment again in these cases. So I will say that one eye already lost. I will say that you already know the patient is one eye very apprehensive. Doing laser is very important. Badly laser is not allowed. You have to personally see to it that the best person who can do laser in this patient should do that laser. Have more frequency. Prime the patient that you will require surgery in some point of time. And I feel if you have done good laser and even if traction progress, the surgery at that time, patient will also be ready that yes, there is something is done. And then surgery outcome also will be better if the laser is done. So I will go with this, I feel.
Yeah.
Okay. I'll give a small analogy to cataract. One small point. I'll give a small analogy to cataract. We were taught that if you get a patient with a PC rent in the other eye operated elsewhere, don't think that it is going to be an easy surgery because this eye may also behave badly. So again, here he had a bad surgery in one eye. Don't presume that the surgery was done badly. He per se may be responding badly. So you have to be extra careful in these cases.
True. Agreed.
Rekha?
Have we changed the topic?
Case of. Shall I go ahead with this, sir?
Yeah, please.
Please.
This is a 52-year-old male who is a driver by profession. On a best corrected visual acuity in right eye was 618 N8 and left eye was 636 N10. On slit lamp examination, both eye has nuclear sclerosis grade 2 with dense cortical cataract. Right eye OCT, already it's supposed 3 anti-VEGF injections done elsewhere. A slight amount of edema is there. Do you go ahead with cataract alone, or do you want to go ahead with a cataract with injection, or you will go ahead with one more injection and plan for the cataract? The second, the left eye, it's a post 4 injections.
Okay. We will take the question now and then move on. I think it will get confusing otherwise.
Yeah. So OD, what she wants is edema is not so much, but there is a tendency for edema. So should we just do a cataract surgery and then look at what the edema is going to progress and then treat it accordingly? Or should we just go give a injection followed by a cataract surgery or a simultaneous cataract surgery with injection?
So this, you have to keep in mind that
after cataract surgery, so do you want to prophylactically give anti-VEGF along with cataract surgery, or how you want to go ahead?
Yeah, this is not a naive patient. This is a patient who's been undergoing treatment, and there's a chance of even without cataract surgery, there's a chance of recurrence. So in this particular case, I would prefer to go with a combo, cataract and injection, because it's a patient who's under therapy and has got injection recently also. So sometimes during the waning phase after cataract surgery, you have a slight increase in thickening, and especially the patient is going to recur. He may get very upset with this post-op vision. So I feel it is critical that we combine, at least in this particular scenario. I feel it is The main thing is to go for combo.
Okay. Vinay?
If he has been stable for, I don't know about when was the last injection given, but if this patient was stable for 3 to 4 months, then probably I'll just go with a cataract, but prime him that he might require an injection later on. But yeah, if I agree, in case the injection was given, say, within a month or month and a half back, then I would probably give an injection along with that. So it depends upon what stage of disease it is. If it is stable for 3-4 months, I'll probably take my chance, do a cataract, prime him for a potential injection later on. Otherwise, I'll give an injection.
Okay.
I would prefer to go ahead with cataract along with intravitreal injection in these cases, because if you have a recurrence, then it is going to be difficult in these cases. It's always better to prevent recurrence in these cases. Once you have recurrence,
Okay,
then
all
it's not
three of
going
you
to
have
stay
told
with
that
single injection.
all three of you have said that you will require an injection. So what is the injection that you prefer? Is it an anti-VEGF or is it a longer acting steroid?
I would prefer a steroid if there is no contraindication, especially if it's not a steroid responder. I would prefer Ozurdex in this particular case.
Okay.
I'll go with anti-VEGF, whatever he has been taking earlier. But again, I said if he has been stable for 3 months, I probably will take my chance and not offer him any injection at all also.
All right. Prakash?
Evidence shows slightly better results with steroid combined with cataracts. I mean, when you combine it with cataract surgery. So maybe I would prefer steroid in these cases. Even tricot should be fine.
Okay. Prashant, any difference in opinion that you have? You have unmuted yourself.
I would just go. What I would do is I would use a IVTA along with a cataract surgery. Simple. If it is not precipitating, any precipitated edema is not there, why go for a Ozurdex at this point? And a month later, we get a window of 1 month, then we can revise our treatment based on the findings.
Dinesh Talwar is silently smiling. I don't know why Mr. Smile is.
See, as Vinay said, there are two scenarios there. You have a patient who doesn't have the edema and has not had edema for the last few months. Then I don't think there's an indication for treating with anti-VEGF before it occurs. This is not a prophylactic treatment. Anti-VEGF treatment is not a prophylactic treatment. But if, on the other hand, the patient has, as Sarvanan said, that he had edema, which just became okay, which was given, injections given a month back, he's okay now. That is not an indication. Then he needs an injection before he goes in for the surgery. And my timing usually for the injection is that I like to give it 7 to 10 days before the surgery, so that the maximum effect of the anti-VEGF is there when the cataract is done. And the other important thing is, in 3 weeks, when the wound has healed, if I need to repeat the injection, I'm ready for that repeat also. So I like to time it like that.
Okay, sir. Now, Rekha, can you talk about the second case? Yeah. Rajkumar can take it.
Coming to the left eye, patient was status post 4 injections of anti-VEGF. As there were hard exudates which are commencing towards the fovea, went ahead with a dexamethasone injection. After 1 month, the edema resolved. After 2 months, it's completely, and 3rd month, it's completely resolved. I followed up after every 2 months, and after 5 months, there is a recurrence of edema. Now he wants to go ahead with a cataract. So do you want to go ahead with a cataract with dexamethasone, or do you want to go ahead with a cataract with an anti-VEGF? Which will be the better option in this case?
Rekha, can I get this answer? Whether you're given steroid before or anti-VEGF before? I just missed that part.
The first anti-VEGF were given elsewhere. I have gone with the Ozurdex. After 3 months, it's completely resolved. Followed again, the edema recurred, or an anti-VEGF.
Okay, I missed you in between because I think your internet issue is there. Anyway, I'll be taking as a new patient if I see that. First thing, you said there is a lot of hard exudate around the foveal region. So when I see hard exudate around the foveal region, I don't go immediately with the injection. I'll make sure patient parameters are fine. And even if the parameters are fine, I'd like to give statin for 2-3 months. I would like to see reduction of hard exudate around the fovea, because these are not short-term treatment. They are going to be long-term treatment. Then many times when we try to reduce edema, this hard exudate get precipitated in the fovea, patient ultimately lose vision. So first thing, I'll like to give statin for 2-3 months to reduce the cholesterol from the macular region. Second thing, if the patient is responding with anti-VEGF, I'd like to continue with anti-VEGF. But then if it's not responding, I might do cataract along with the steroid injection.
Okay.
What's your take, sir? Dr. Prashant?
Yeah, for me, I would be steroid because trauma surgery per se is a trauma. There is an inflammatory component which is further added to it. So it is prudent enough to add just a simple IVTA as the first line of treatment with a regressing edema. I think that is better. Phaco with a intravitreal triamcinolone, as simple as that.
Actually, this is not a regressing edema. It's a recurrent edema. Now it's come back.
It's a recurrent, yeah.
So it's no longer, it's not, it was regressing. 6 months have gone by. It's coming back. There's no risk of a rebound. I mean, there's no risk of a steroid additive effect. So this is the situation where giving another Ozurdex will probably be more effective than giving the antibiotic.
Yes, if patient is affording, definitely Ozurdex.
Yes. So because with triamcinolone, if you give lower dose, 1-2 milligram, you'll need to repeat it faster. If you give 4 milligram, then the risks of glaucoma will go up too much.
All right. But this is a slightly oversimplified case because the patient very well responded to Ozurdex. So my choice is definitely going to be Ozurdex again. And it remains stable for 6 months, and 6 months only there is a recurrence happening. So this case, there is no significant doubt. But let us talk about a chronic diabetic macular edema, which requires multiple injections. Do you wish that the edema be completely gone before you do the cataract surgery, especially if the cataract is accounting for maybe 1 or 1.5 lines of decrease of vision? Or do you want that you can just
Gopal, when you say chronic macular edema, we are assuming that already structural damages has happened, and these cases are going to be very resistant to whatever treatment you are going to give anti-VEGF. So it's important you rehabilitate the patient visually as early as possible, and you can evaluate also better. So I would prefer to do cataract surgery at the first place itself if it is chronic macular edema. But if it is acute macular edema where there is no structural damages happened, I would wait till maximum response. If I can do an OCT, convenient OCT, I mean readable OCT, then I would prefer to do injections till macular edema responds the maximum. Once it is not responding further, I would combine a cataract surgery with an intravitreal injection at that point of time.
Well said.
Chances are that you're giving steroids, the cataract is anyway going to be progressing very fast in these cases anyway. So, but I'm impressed by your drivers getting paid so much that they can afford so many injections of Ozurdex and other things also. So Kerala is a good place for payments, huh?
I don't think so.
He's driver in the Gulf.
Okay, fine. Now that makes sense. That makes sense. Driver by profession. That makes sense.
The rate of progression of cataract is not very high with Ozurdex. So that's not true. That's the rate of progression of cataract would be very fast. But at the same time, I don't repeat. I would not like to repeat the Ozurdex more than once in 6 months as a rule. In the usual situation.
Okay, so I think we have shot our time by a long way. Not our time. We have basically taken only 1 hour and 7 minutes. It's
no, Gopal. No issues. You are almost on time, and see some more discussions if you want. You can have, and probably you can conclude by summarizing the points in each discussion, so that it's sort of like take-home point for each.
Yeah. So I will ask each of the panelists to conclude the each of the case that we discussed. Vinay, you can talk about you already concluded about the first case, the asymptomatic lattice. Yeah. Can you?
Yeah. So basically, one thing that we all agreed upon is that the refractive surgery does not pose any additional risk to the retinal detachment in case of a lattices. So that is one thing out of the way. The other question was whether asymptomatic lattice requires treatment. We again agree that the risk is very low, but now whether we want to take that risk or not. So since the risk of laser, a properly done laser is also very low. So we agree that we would like to do a laser, but we have to be careful about not doing overburning of the treatment, not going too close to the lesions, giving only 2 rows, doing it over multiple settings, and all those things that were discussed in the session.
Okay, Rekha, FFA versus OCT angiography.
I'm not using an OCT angio.
Okay, Saravanan, can you talk about FFA versus OCT?
Right now, as with current so-called advancements, still the role of OCT is still a little largely not into mainstream practice, especially. That's one of the reasons why most centers do not have it. Plus, as rightly pointed out, in uveitic entities and the leakage component cannot be assessed with the OCTA. Still, it's a long way to go. Probably in the coming years, we'll see more and more device innovations which will make it to mainstream. But right now, it's not mainstream. Definitely not.
Yeah, maybe in 2 to 3 years, we will eat our own words.
Probably.
Yeah, Prakash, can you talk about the diabetic macular edema, when to switch, and Dr. Dinesh Talwar can definitely add on.
Yeah, so in a case of diabetic macular edema, if the response is 0, there is no response at all, we would go at 1 or 2 injection itself, we will think of switching treatment. But if there is some response, we assess it at the end of 3 months, see if it is less than 20% response, then again we will classify it as poor responder and consider switching treatment at that point of time. If it is improving, we will continue. More than 20% response is there, we would continue with the anti-VEGF itself.
But combination simultaneous anti-VEGF plus Ozurdex is what is recommended today by Dr. Dinesh Talwar to have 20-letter improvement over the first 3 to 4 months.
I think we should all look at it. I think it's worth
protocol U. No, but when you look at protocol, you didn't show that kind of response in those combination. That is the only study which have an RCT where you have combined both the treatments. But protocol you didn't show.
This was also a randomized controlled trial, but it was a smaller one. The protocol
look into the
patients with recalcitrant macular edema. These are treatment
protocol you had another disadvantage also.
It's a different
protocol U.
And the other thing which nobody goes into the detail of protocol U, are you aware that in 10% of patients in protocol U, combination therapy patients got more than 3-line improvement, as opposed to only 1% in the patients who were on monotherapy. Again, in patients with more than 2-line improvement, there was a trend towards higher improvements in the patients who were on combination therapy as compared to patients who were on monotherapy with ranibizumab. And finally, there was a huge improvement in the central macular thickness in patients on combination therapy, which did not translate into so much vision gain, possibly because these already had structural loss to a large extent. So it's important to keep that in mind.
Yeah, Rajkumar, very rapid.
I have few sets of patients in which the macular edema is very gross, and if they are pseudophakic, I go ahead with the interval Picot with the Avastin first go itself, and I followed with the anti-VEGF. And I see a good response to those patients, but not generalizing to all the patients.
I think I would just give one message in this. Start with anti-VEGF. If in your first 3 anti-VEGF, you get anything between 7 to 10 letter improvement, please continue with the anti-VEGF therapy. You don't need anything more. If you're on ranibizumab, you have 25% such patients. And if you're on aflibercept, you have 50% such patients. If the patient does not get this response, please shift him to steroid, a long-acting steroid like Ozurdex, and continue the anti-VEGF along with it. And you'll probably get the best results by this combination. So the important thing is, those who do not have any change in OCT or in vision in 3 consecutive follow-ups, they need to be changed. They need a switch.
Sure, sir. Sure. I think Sreeni is indicating us to stop. And it was a wonderful 1 hour and 15 minutes of discussion. Thank you, Dr. Dinesh Talwar, Dr. Saravanan, Dr. Prashant Bavankule, Dr. Vinay Garodia, and our own Prakash and Rajkumar. And thank you, Rekha, for this wonderful presentation that you have made. And thank you very much.
Thank you so much. Thank you.
Bye. Thank you.
Yeah. Thank you, Gopal. As usual.